Vivek.
Okay, we will be starting shortly. There is some technical glitch. We'll be starting at 2:05. Just bear with us.
Good afternoon, ladies and gentlemen. I, Dr. Bhumika, take this opportunity to welcome you all to the first international CME on viral hepatitis, organized by Department of Clinical Microbiology and Infectious Diseases, All India Institute of Medical Sciences, Rajkot. In the field of hepatitis in general and viral hepatitis in particular. The organizing committee extends a very warm welcome to all the speakers for CME. We shall start the proceedings shortly with the inaugural address. Professor Dr. Colonel C.D.S. Cutout, Executive Director and CEO AIIMS Rajkot, is the Chief Patron for CME. Unfortunately, he is not able to attend the event as he is traveling for some unavoidable commitments. Sir has been the pillar of support for all our endeavors and he deeply values this CME. He has conveyed his best wishes for the event and he will be joining us virtually whenever possible. On his behalf, it is my pleasure to welcome all delegates from India and abroad who have joined us online and distinguished guests present with us to the first international CME on viral hepatitis. We shall now begin with today's deliberations. Over the next 2.5 hours, we have experts from the field deliberating on the current status of viral hepatitis, the progress and achievements in our fight against the disease, and gaps and needs in our efforts to eliminate the disease as a public health concern. Delegates may post their queries in the chat box. We will try to address them at the end of the session. In case time, we will shortly report you back by email. So, without further ado, let's get started. I would like to introduce you all with our first speaker, Dr. Ashwini Agarwal. He is an alumnus of the prestigious Armed Forces Medical College, Pune. He served in Army for more than 25 years, during which he was posted in leading tertiary hospitals and teaching institutes of armed forces. He was professor in microbiology at his alma mater before he decided to hang up his uniform. Dr. Agarwal is a passionate teacher and diligent researcher. Currently, he is working as professor and head Department of Clinical Microbiology and Infectious Diseases and Vice Dean Research at AIIMS Rajkot. He was heading Department of Microbiology at AIIMS Jodhpur before joining the present appointment. He has numerous publications and research awards to his credit. His special interest is in the field of infectious diseases and tuberculosis diagnostics. Over to you, sir. Dr. Ashwini Agarwal.
Am I audible?
Yes, sir.
Thank you. I am sorry for the technical glitch. Actually, our institute is still in a budding stage, and this is the very first CME being organized with us. And it's a matter of immense pleasure and pride for us that we have received an overwhelming response with 1,000+ registration for the CME. So what we started with a small national CME has turned into international one with many participants from abroad also. Thank you all for believing in us, and I sincerely hope that this CME is fruitful for you. I also take this opportunity to thank my co-speakers. We have with us today Dr. Ekta Gupta from ILBS New Delhi, who will be speaking on elimination of viral hepatitis. That is the viral hepatitis control program. Then we have Dr. Ashok Choudhury, who is a renowned hepatologist, who will be speaking on management of viral hepatitis. And last but not the least, we have Dr. Pragya from AIIMS Raipur, who will be deliberating on acute viral hepatitis, that is demystifying the hepatitis A and E. My job is the easiest one, that is to set the ball rolling for them and tell you about the burden of viral hepatitis. So let's get started. Just think of three big infectious diseases. The diseases which come in our minds are probably tuberculosis, malaria, and HIV/AIDS. Yes, truly they are global concern. They are cause of a big morbidity and mortality, but their significance is known since long, and we have national control program or elimination program in place for them since long. So what was realized during last decade, that there is one more disease which is equated as a threat comparable to these three big infectious diseases. During that time, it was the seventh leading cause of mortality worldwide, and the disease is none other than viral hepatitis. It is only communicable disease where mortality is increasing. In 2015, 1.34 million deaths occurred due to viral hepatitis. That is around 3,000 people dying every day of liver disease caused by viral hepatitis. So it is surely a very big problem. Institute for Health Metric and Evaluation, they gave an estimate which was published in NEJM in 2019, that in 2017, estimated deaths due to viral hepatitis outnumbered all tuberculosis, HIV, and malaria. And they also predicted that number is going to exceed the combined mortality of tuberculosis, HIV, and malaria by the year 2040. So viral hepatitis is really a global public health challenge, which had been largely ignored as a health and development priority. So this was included by United Nations in their Sustainable Development Goal under the Goal 3, that is good health and well-being. And UN called for specific actions to combat viral hepatitis with huge opportunities for action. So this target was included in the UN agenda. Coming to the basics of viral hepatitis, we all know that hepatitis is caused by these 5 viruses named A to E. So remembering it on our fingertips, we have our little finger, which signifies the viral hepatitis A, which is transmitted predominantly by fecal-oral route and causes acute hepatitis in children. The thumb represents viral hepatitis E, which causes acute hepatitis in young adults and adolescents. Both of them are transmitted by fecal-oral transmission and cause acute hepatitis, while B and C, which are represented by ring finger and middle finger, they are transmitted by parental transmission and are predominant cause of chronic hepatitis infection. D, which is generally associated with hepatitis B, is rarely present for India, luckily for us. So coming to HIV and HIV, Dr. Pragya will be speaking in detail on this topic, but this generally causes outbreaks or occur sporadically. The disease is generally self-limiting, but in certain cases, it can lead to fulminant hepatitis, which can be fatal. Prevention can be by improved sanitation, personal hygiene, and food safety. There is an effective vaccine available for HIV. In fact, there are many vaccines available for HIV and which provide lifelong protection. For HIV, there is a Chinese vaccine which is licensed in China only. So HIV vaccine is again desirable for rest of the world. The map shows global HIV epidemiology, and as you can see that India is in dark red region, which means that it is high prevalent region with more than 90%, where more than 90% of children have immunity by age of 10. HIV, humans are the only reservoirs for hepatitis A infection, although 90% of children have immunity. It's only 10% of them which manifest symptoms in the form of jaundice. Rest 90% remain asymptomatic. It may cause severe disease if the disease is acquired in older age group. In less than 1% patients, serious consequences may occur. Generally, they occur in patients with risk factor like pre-existing liver disease, example, chronic liver disease, chronic kidney disease, or in immunocompromised conditions. Coming to HIV, this map shows the global HIV epidemiology. Again, India is in highly endemic zone in dark purple color. Again, associated with poor hygiene and sanitation, there are 4 genotypes. Genotype 1 and 2 are found only in humans, while 3 and 4 circulate in animals, and they are more prevalent in the areas which have low prevalence of HIV. Generally, HIV also causes acute infection only, but rarely it can cause chronic HIV infection. And in these cases, genotype 3 and 4 are generally responsible. These infections are reported in immunosuppressed patients, generally organ transplant recipient or the patient on immunosuppressive drugs. Rarely, acute hepatitis E can be severe and result in fulminant hepatitis, leading to death. The infection can be particularly severe in pregnancy if acquired in second and third trimester, where there is increased risk of acute liver failure, both in mother and child. So it can lead to fetal loss and mortality. This is a study conducted at Sher-e Kashmir in J&K, India, in which 72 pregnant women were followed up who had HIV infection. Out of this 72, the 7 mother died undelivered. That is, mortality was around 10%. 3 had abortion and 60 gave live birth. But out of those 60, only 14 fetuses were non-infected. Rest infants were found infected. So out of 46 infected infants, almost 50% of them developed severe neonatal disease, had severe hepatic necrosis and died, while rest of them had icteric or inicteric HIV infection, which recovered. So almost 50% of the liveborns of HIV positive mother died. So this infection can be really serious in fetuses, for fetuses and pregnant females. Coming to hepatitis B virus and hepatitis C virus, both of them have an indolent course for almost a decade. They lead to chronic hepatitis, and further from chronic hepatitis, in next 2 to 3 decades, they can lead to development of cirrhosis and further other sequelae like hepatocellular carcinoma and stage liver disease or deaths. Generally, it takes 3 to 4 decades after acquiring infection. As per WHO estimates of 2019, there were 296 million people worldwide living with hepatitis B and 58 million people worldwide living with hepatitis C. And almost 1.5 million people get newly infected with chronic hepatitis B and C, respectively. WHO also estimated that hepatitis B caused 840,000 deaths and hepatitis C caused 2.9 lakh deaths. So total hepatitis B and C together caused more than 1.1 million deaths during 2019. Hepatitis E accounted for 3.3% death, while hepatitis A only 0.5%. So it's hepatitis B and C combined, which accounts for more than 96% of mortality due to viral hepatitis. So every 30 someone loses their life to either hepatitis B or C. This is Dr. Baruch Samuel Bloomberg, who was awarded Nobel Prize in the 1976 for his discovery of hepatitis B virus in 1967. He not only discovered hepatitis B virus, but also developed the blood test to detect HBV and further went on to invent the hepatitis B vaccine. So today, on 28th July, is his birthday, and this day we celebrate as World Hepatitis Day to commemorate his contributions and achievement to the field of hepatitis. Hepatitis B is transmitted via percutaneous or mucous membrane contact with infected blood or bodily fluid, and it is 50 to 100 times more infectious than HIV. So in high prevalence country, the predominant mode of transmission is perinatal transmission. Perinatal transmission, that is, the infection is passed from the mother to the child, the mother who is already infected with HPV. In India also, almost 30% of cases occurs because of perinatal transmission. But the mode of transmission which is more common in India is the horizontal transmission, which occurs due to exposure of infected blood, especially from an infected child living in the same household to an uninfected child during the first 5 years of life. Other mode of transmission like sexual transmission or IV drug use are more seen in low prevalence countries. This graph shows global HPV epidemiology. The darker the red color, the more is the prevalence. Low intermediate zone to 4%. WHO regions, Western Pacific has maximum prevalence of HPV, followed by Africa, and then we have Southeast Asia, Europe, and Americas. So Southeast Asia lies somewhere in between. Global prevalence also very intermediate, low intermediate, and low depending upon the prevalence. India, as you can see, lie in the low intermediate zone with prevalence of around 3 to 4%. Hepatitis B causes acute infection, and from acute infection, more than 90% of children who are less than 5 years of age develop chronic disease, while less than 5% of adults progress to develop chronic disease. So when chronicity is established, 5 to 10% of chronic HBV infected individual go on to develop hepatocellular carcinoma, while 20 to 30% of them go on to develop cancer or cirrhosis, may lead to death. Cirrhosis can lead to decompensation and death. Chronic HBV infection in India, we have almost around 40 million cases. It accounts for almost 40% of hepatocellular carcinoma cases and 20 to 30% cases of cirrhosis. Various studies have been done across India to determine the prevalence of HPV, but they have given different prevalence rate in different geographical areas, communities, and social groups. The prevalence is as high as 60% in some of the tribal areas like Jarvas of Andaman and Nicobar Island, and as low as 0.2% among blood donors. HBsAg seroprevalence is estimated to be around 3 to 4.2% in various systemic analysis. Study was conducted the national DBS samples. They were subjected to hepatitis B screening also. This gave a prevalence of around 0.95%. There was also population heterogeneity. The seroprevalence was higher in male, increases with age, higher in rural areas. It was found highest among scheduled tribes, and increased seroprevalence was observed among the high-risk sexual intercourse individuals. there is no virological cure for chronic HBV infection. It requires long-term monitoring and treatment to control viral replication and to prevent long-term complication and transmission. So there are drugs available which can treat the patient, but there is no cure for the patient. So in 2021, WHO estimated that 12 to 25% of people with chronic hepatitis B infection will require treatment depending upon setting and eligibility criteria. Recently, in 2023 update, WHO has expanded this treatment eligibility, which will lead to increase in proportion of people on treatment. So a treatment is there, but no cure is there. However, an effective vaccine is available for hepatitis B, which provides protection for at least 20 years and maybe lifelong. WHO recommends that first dose of this vaccine should be given as soon as possible after birth, that this is the birth dose, and preferably within 24 hours of birth. This should be followed by 3 doses at 6, 10, and 14 weeks for completion of primary immunization. All healthcare workers should also receive HPV immunization. So this HPV vaccine was introduced in Universal Immunization Program as a pilot project during the year 2002 and 2003. The phase expanded, and during phase 1, it was expanded to 10 states. And during phase 2, it was introduced in entire countries in the 2011 and 12. And also to prevent its complication. This is a study done in China where the prevalence was compared before introducing the vaccine in Universal Immunization Program and after introduction of vaccine in UIP. So as it shows that there was a tremendous decrease in seroprevalence of hepatitis B after introduction of vaccine. Similarly, this is a study from Taiwan which shows its impact on hepatocellular carcinoma in different age groups. Again, the incidence of hepatocellular carcinoma showed marked reduction after introduction of vaccine in the program. So unvaccinated one had higher chances of developing hepatocellular carcinoma in comparison to the vaccinated ones. This map shows the global coverage of birth dose of hepatitis B vaccine. It is around 40-60% in India now, but if you see that Western Pacific region, which has the highest prevalence otherwise, is well covered, but in Africa, only 16 countries out of 40 plus countries have taken up this birth dose hepatitis B vaccine in their program. India has it, but the coverage is around 40-60%. The situation is better for 3-dose hepatitis B vaccine, both in Western Pacific and Africa. Overall, it is around 85-86%. And in India also, we have this much coverage. Coming to hepatitis C, the hepatitis C was not known to exist not long back. During 1970s, it was realized that there is some virus which is causing transmitted hepatitis, and it is neither A nor B. So it was earlier named as non-A, non-B hepatitis virus. It was only in 1989 that HCV was identified, given its name, and later the characterization of this virus was done, diagnostic tests were developed, and the treatment was also evolved. So these 3 gentlemen, Charles Rice, Alter, and Michael Houghton, they were awarded Nobel Prize for their discovery and the characterization of hepatitis C virus in 1920, just 2 years back. Hepatitis C is also a bloodborne virus, but here most infection occurs through exposure of blood from unsafe injection practices, unsafe medical procedures, or transfusion of unscreened blood transfusion. Perinatal transmission or sexual transmission is less common in hepatitis C in comparison to hepatitis B. Hepatitis C infection, almost 55 to 85% of patients develop chronic hepatitis. Rest 15 to 45% of patients, they develop acute hepatitis only and go spontaneous clearance of the virus. So these 55 to 85% of patients who develop chronic hepatitis, they further go on, almost 20 to 30% of them further go on to develop cirrhosis, and the patients with cirrhosis have annual risk of developing hepatocellular carcinoma of around 1 to 4% and end-stage liver disease of 2 to 5%. That is the annual risk. This graph shows the HIV epidemiology and genotype distribution of hepatitis C virus in the world. Genotype 1 is the commonest one, which is seen in around 46% of patients in regions, and genotype 3 is the second commonest, seen in 22%, followed by genotype 2 and 4, accounting for 13% each. In India, genotype 3 is the commonest one, followed by genotype 1. It is estimated that India has around 6 to 12 millions of chronic HCV infection patients. 12 to 32% of HCC, hepatocellular carcinoma, occurs because of hepatitis C infection, and 12 to 20% of cases of cirrhosis occurs because of hepatitis C infection. Again, the estimated burden of hepatitis C in India is wide-ranged, mainly due to positive data. Different studies have suggested different seroprevalence. So, seroprevalence is found to range from 0.19% to 53.7% in different studies. But as per the NCDC data, which was published in 2021, the national seroprevalence was found to be 0.32%. This number may seem small, but in a country with a population of more than 1.4 billion, this will transform into a very large number. The incidence was also found higher in men and increases with age. Here, the prevalence was more in urban areas than rural areas, while hepatitis B was more in rural areas. It was highest among scheduled tribes, and increased seroprevalence was also observed in persons with high-risk sexual behavior. There is no hepatitis C vaccine available as yet, but there are effective drugs which can cure more than 95% of patients. So these drugs are direct acting antiviral medicines, and WHO now recommends a pan-genotypic DAS for all adults with chronic hepatitis C infection. And last year, to this gamut, adolescent and children up to more than 3 years of age were also added. So pan-genotypic direct acting antiviral drugs should be given for anyone who is more than 3 years old and suffering from chronic hepatitis C infection. However, these drugs are costly and access to treatment is also a problem. So in 2009, it is estimated that only 21% of the 58 million people with chronic hepatitis C infection were diagnosed and only 13% were treated. So, realizing the problem and in line with the UN goals, WHO approved the Global Health Strategy to combat viral hepatitis, and they gave certain goals that by 2030, the number of new infections caused by hepatitis B and C should be reduced by 90%, reducing hepatitis-related death from liver cirrhosis and HCC by 65%. At least 90% of people with hepatitis B or C virus should be diagnosed, and at least 80% of patients who are eligible for treatment should receive treatment. So these were the target they set for the world, and all the member countries, they signed it. India is also one of the signatory, and in 2018, India launched its National Viral Hepatitis Control Program. So Dr. Ekta will be speaking in detail on the program. This program provides screening, diagnosis, and counseling service free of cost to all. And it also provides free of charge algorithm-based treatment of chronic hepatitis B and C. Having said all this, we have introduced the program, but there are still gaps in hepatitis control, which include a limited availability of reliable national or state epidemiological data. Without it, planning any program is almost impossible. So we still have very limited data, reliable data available as far as hepatitis is concerned. Second important gap is low awareness amongst the general population, even healthcare personnel and politicians. Politicians are important because they are going to fund the program. The pockets of hyperendemicity, they are again a problem, like tribal areas or isolated communities which have high seroprevalence and low access to preventive and testing services. Almost 90% of people living with viral hepatitis are unaware that they have it. There is a vaccine hepatitis, but its coverage has to be improved. There is no cure, so getting a patient to take full treatment is difficult. So poor treatment adherence is also a problem. For hepatitis C, there is no vaccine available, but effective cure is there. But the testing and therapy both are costly. In recent past, the cost has come down drastically, but still access to treatment is a problem. Certain people who have failure on these drugs, very limited armamentarium is available for them. Ensuring compliance to therapy is also a problem. Almost 15% of patients default despite free treatment. So the way forward would be to promote greater public, healthcare personnel, and political awareness so that they know about the viral hepatitis and take action for this. The CME is a part of this. Politicians have to allocate increased financial resources to combat viral hepatitis B and C. The access to hepatitis B and hepatitis C testing and care has to be expanded by introducing decentralized care models. Harm reduction in key population is to be done. Hepatitis B immunization coverage has to be improved with more emphasis on birth dose of hepatitis B. Improved services for testing of pregnant women for preventing the vertical transmission of hepatitis B, because it accounts for almost 30% of cases, has to be done. The current diagnostic tests have certain limitations. So these have to be looked into by more research and development. A new research is also required, focusing on developing curative treatment strategies for hepatitis B virus and a preventive vaccine for hepatitis C virus. This graph is recently published by WHO in their Global Health Sector Strategies for 2022 to 2030. They said that if these actions are taken, then it will lead to reduction in the prevalence of hepatitis B and C, and we can achieve the target by 2030. But if they are not taken, then it is not possible. So the dotted line shows that the prevalence will again going to rise. Similar is the case for hepatitis C. So both hepatitis B and C, they can be eliminated, but the path is difficult. So it's time to act. All these actions have to be taken. One life and one liver is the theme for this hepatitis day. Both are important. We have to preserve both, and viral hepatitis can devastate both. So we have to act, and this is time to act. Thank you very much. In case there are any questions. We will take the questions at the end of the session. Thank you. There is a question that after needleistic injury to a healthcare worker who is documented responder anti-HBs AG more than 10, what will be the post-exposure prophylaxis, sir? Second out, what if healthcare worker is documented responder, but during course of the time, their titer falls and now healthcare worker is exposed to MSI, should be the PEP now. Okay, so if the titer is more than 10, then no more vaccination is required, no post-exposure prophylaxis is required. Next question is booster dosage necessary for healthcare professional every 5 years after initial immunization? Now, as I told that vaccine is quite efficacious, it provides protection for almost 20 years and maybe lifelong. So even after 20 years, booster dose is not required. You can get your antibody titers checked. If it is more than 10, then there is no need of booster dose. We will start the next session. Whatever questions are there, you can post in the chat box and we will revert back at the end of session.
Thank you so much, Dr. Agarwal, for this wonderful deliberation on epidemiology of viral hepatitis. Our next speaker is Dr. Ekta Gupta. Ma'am will join us shortly. Dr. Ekta Gupta is the professor and head clinical virology and nodal officer for WHO Collaborative Center on Viral Hepatitis at the Institute of Liver and Biliary Sciences, New Delhi, India. Madam has a keen interest in clinical and diagnostic virology, and she has been working incessantly for the past 2.5 decades. Words will fall short to describe ma'am's contribution in the field of viral hepatitis. Madam has more than 130 scientific publications and she has authored 9 chapters in books. She has to her credit several extramural research grants, both at national and international level. She has special interest in hepatic and transplant related viruses. Ma'am's profound knowledge would undoubtedly captivate our audience and provide them with valuable perspectives on viral hepatitis. We are sorry for the delay. Dr. Ekta ma'am will shortly join us within 2-3 minutes.
Hello, Abhishek, can you hear me? Can you see me?
Yes, ma'am. Yeah. Yes, ma'am. You're
Okay.
audible. क्या हो गया, sir? Hello.
Abhishek, will you share my screen or?
हाँ, मैडम को अपने अपडेट कर दिया ना playlist? Okay.
I think we can upload my presentation from there.
नहीं, unmute कीजिए. Yes, ma'am. Yes, ma'am. We are doing it.
Then I'll keep saying next slide, next. That would be easier.
Yeah.
Because I'm here in
Okay, ma'am.
AIIMS,
Yeah.
ये भोपाल का guest house में, but थोड़ा connectivity problem.
मैम बस 2 मिनट और हो जाएगा.
हाँ, no problem. Yes. Shall I start?
Ma'am, your PPT is live now. You can start. Ma'am.
Yeah, I can see the PPT. Yes, absolutely fine.
Thank you.
Shall I start?
Yeah. Yes, ma'am. Please.
Okay. So, good afternoon, everyone. And I'm extremely sorry for the delay. And first of all, my sincere thanks to the entire Dr. Agarwal and his entire team at AIIMS Rajkot, and especially Abhishek, who has been an excellent student, and attending to his first CME is making me feel as if it is like your own son has got his first paycheck and you are relishing on that. So I'm extremely happy, and congratulations to all of you. I hope you can all hear me clearly. So I bring greetings to you from ILBS, which is in New Delhi. And so the talk I am going to take is on National Viral Hepatitis Control Program in the country. Next slide, please. So when we are talking about why we have started talking about chronic hepatitis, is that it was felt in the year 2016 that the number of deaths and morbidity, mortality associated with hepatitis B and C, especially the chronic B and C, was much, much more than even HIV, tuberculosis, and malaria. Next slide. Next. So that is why the Global Health Summit in 2016, they thought that let us start moving towards removing this as a major public health threat. Hepatitis, and what are the targets? So they have given each and every government certain targets. They want that new cases should be reduced to more than around 90% by 2030, no new infections, and deaths to be reduced by 65%. Next slide. So there were a lot of papers and a lot of literature people started to do that what is happening, why are not we being able to offer very good treatment. So we found that lack of diagnosis was a major gap, whether it was hepatitis B or it was hepatitis C. If you see how many are infected and how many are eligible for treatment and actually being given diagnosed and treated is very, very less. Next slide. And when we talk about India, so the burden of hepatotropic viruses are like the fingers, 5 fingers. A and E are hyperendemic, but it is B, C, D, which are the one which can cause chronic infection. Fortunately, D is very, very low, but hepatitis B, right now we have 40 million, and it can be many, many more because not many studies have been done. For C, it is 12 million, and you can see so much huge. So India actually needed a very well documented control program. So for hepatitis B and C, the treatment was always there in the private sector. Everybody was doing it. But as a national program to bring all this to the public domain was the task force given to us. Next slide. Next slide. We were fortunate, so I was as a WHO nodal officer from ILBS. We were fortunate that we initiated this movement in the country. We got Government of India, we got WHO, and in the year 2014, 15, 16, and 17, we did these meetings, consecutive technical consultative. And next slide. So that by the year 2018, next slide, we actually launched the National Viral Hepatitis Control Program in our country. So this is a control program. These are the guidelines. All these books are freely available. In 2018, we in fact launched it as for only hepatitis B, C, but then in 2019, we also included in it hepatitis B. So remember, India is the only country where hepatitis B and C are both inclusive in the National Viral Hepatitis Control Program. Next slide. And what are the aims next? What are the aims of NVHCP? Now, through this national program, which is being controlled by now central government, it runs through the central government. The health secretary runs it, controls it, and through NCDC, they have made a nodal officer and nodal center at National Center for Disease Control. So the main aim is to eliminate hepatitis C by 2030. Then to reduce the infected population, the mortality and morbidity by both B and C. Again, in this program, we also added the component of at least diagnosing hepatitis A and E and offering and combining it with the other programs like hygiene program, sanitation program, water program, and to control the A and E outbreaks in the country. Next slide. Next. So how this runs in the country, as I told you, that this is a national level program. So this is a public health program. So whenever like tuberculosis control program, HIV control program, they come, they make an entire organization. So that does not mean that from the private sector or local practitioners, B and C diagnosis and treatment will not be done. But it will be, this program only looks after the public sector where the free testing and free treatment can be given. So there is a national program steering committee, technical resource groups at the national level. Fortunately, I'm a part of these national level technical resource group also. Then each state, the program is held by state health mission, and they make model treatment center, model treatment centers, and the labs services. So like the national program gives them fund, but your state has got their own, they can decide on how many treatment sites, how many diagnostic sites, and how many other model treatment and referral labs they can make in their own state. And they will give you, apart from the National Health Mission, they can also give you through their state some funding for this. Next slide. Now, in this program, the focus is on basically screening. We want to screen, as I told you, the gap is we are not even able to catch who are infected. So we are going to focus on a lot of screening now, and we want to decentralize screening as much as possible. So the focus will be on rapid card tests, those card tests for B and C, and A and E. We are trying that such card tests should come into the country, but unfortunately we only have ELISA, so they are provided. So screening is basically by serological test. And anybody who turns out to be positive in the serological is given a confirmatory test by a DNA or a RNA wherever required. Now, treatment for uncomplicated. So when hepatitis B and C, uncomplicated, I mean the liver is preserved. So there is no cirrhosis, there is no other metabolic syndrome, there is no other renal and other attributable factor. So uncomplicated cases can be managed at simple, primary health centers or district offices, and medical offices can give treatment. However, the treatment of complicated cases, if it is a cirrhotic liver, there is a co-associated comorbidities, then they need to be sent to a model treatment center. Next. So in diagnosis, now the program runs is that at a primary health center, only the serological screening will be done. District hospitals, they should be the ones where at least ELISA or access to RT-PCR sending lab should be there. State level pay, you should have RDT, ELISA, CLIA, and access to RT-PCR, and there will be sentinel sites and some center of excellence where the entire panel of diagnostics, including even the sequencing, will be made available. So this is how this model has been proposed. Next. Next. And treatment-wise, we have made that the sub-district level, like the primary health centers, they should be drug dispensing. So we will, it is ensured that at these sites, at least for hepatitis C and B, the basic drugs are available for uncomplicated cases. In case of complicated cases, they can go to the proper treatment centers. And then if there is more management is needed, then at the medical colleges or tertiary care level. So wherever your health center is, you can actually ask your state to make that kind of a center for you. So you can, in the microbiology, you can become simple state level testing lab. You can also become a referral lab, or also you can become the center of excellence. If you have a gastroenterology or a medical unit, then you can become district hospital treatment center TCs, or you can also become model treatment center MTC. Next. Next. I think the slideshow has gone. Can you hear me?
Yes, ma'am, we can hear you, but slide not visible.
1 second, ma'am. We are doing it.
Okay.
Yeah. Next. So the guidelines. This is very important, that how B and C are going to be dealt with in this through the national program. Next. So I'll not take much. Next. Now, when we talk about hepatitis B virus, we all know it is a DNA virus. It is a partially double-stranded DNA virus. The important in diagnosis for hepatitis B is the surface antigen, which is expressed and you can actually pick up infection with it. Then if a person seroconverts, then antibody to surface antigen, which tells you about protection, whether following an infection or after vaccination. Core antigen is an important antigen, but it is not present in the blood. It is there inside the liver only. So antibody to the core in the form of IgM, which tells you about acute hepatitis B, and IgG plus IgM, which is total, which tells you about exposure. E antigen and anti-E were earlier used, but nowadays, because of the mutants which are coming up, this is not a very relevant marker. Next. Now, once you have exposure to hepatitis B, we call it acute infection. Mostly the adults, when they acquire, they're able to clear the virus because of a very robust immune response, and we call it acute hepatitis B. Now, once mother to younger the age, so if the transmission of the virus is from mother to child, the children, they fail to recognize this virus as any foreign particle, so they remain. So the chronicity is maximum if the younger the child is, or whether it is transmission at the time of birth or following birth, and then the chronic infection comes. Now, this is the chronic infection which we are targeting to treat. So acute infection gets cleared. But only thing I have to tell you is that, as you can see in the diagram, the virus gets integrated into the new host chromosome and as a CCC DNA reservoir inside the hepatocyte. So the virus, once you get, is never cleared from the body. It's only the blood virus which gets cleared by the immune response. Next. So what are the, so this diagram I wanted to show, if there are microbiologists, that there are 4 phases, or rather 5 phases of hepatitis B. They are nothing, but as the virus enters and how our immune system tackles it, the names are depending on this. Now, when is the treatment given in hepatitis B infection? The treatment is needed whenever there is a damage to the liver happening, that is, which is depicted by abnormal ALT. So phase 2 and phase 4. Now, these are the one earlier known as immune reactive and immune escape, but now we call them hepatitis phase. One, E antigen positive hepatitis, the other E antigen negative hepatitis. Now, these are the phases where our treatment goes. I wanted to show you this diagram so that you all know that the virus can remain for a lifelong. It may remain under immune control for many, many years, but can get reactivated. So next. So the treatment strategy, next slide, is based upon your liver damage. Now, this is a strategy which we use in our national program. So if anybody is hepatitis B surface antigen positive, unlike hepatitis C, we immediately don't go to DNA. We first want to see whether the liver damage has been there or not. And how do we see the liver damage? You can see it by fibrosis. You can calculate by non-invasive ultrasound, which is FibroScan, or EPRI, which is a aspartate to platelet ratio, and looking at the ALT, which is a liver function test. Now, anything by which the cirrhosis is established, you should start the treatment irrespective of DNA. But if the cirrhosis is not established, in that case, we go for ALT and DNA. And just to tell you that more than 20,000 is considered as a significant DNA where the treatment is given. Now, why are we not giving treatment to all? Because this is right now, we don't know the stopping rule for this hepatitis B treatment. Once you put a patient on treatment, it has to be lifelong. So that is why the clinicians do not, so there is a debate happening. Should we treat all or should we not treat all? So what we have landed up is that we should only treat if a established liver damage in the form of abnormal ALT or cirrhosis of the liver is seen, then only the treatment is given. Now, once you put the patient on treatment, then you start monitoring only by DNA because the treatment targets DNA. So we are interested in seeing the DNA clearance, which tells you about the virological response. So this is so in the national program, hepatitis B, we identify hepatitis B surface antigen positivity. You do ultrasound, fibroscan, APRI score, and DNA, and then you give treatment, and treatment is given lifelong to the patient till now, right? And the monitoring is also done. Next. So these are the drugs which are actually available because under the national program. So you have TDF, TAF, all the latest form of tenofovir is available, entecavir, which is also available. So these are the drugs which are available under the program. So you can give free treatment, free DNA, and can maintain a patient on a lifelong treatment. Next. Now coming to hepatitis C. So the hepatitis B under the national program is very simple, how it is diagnosed and managed. I hope you all have, I have made it clear. In hepatitis C virus, which is a very cleaner virus, we just look for infection by doing an antibody assay. Now, antibody to HCV tells you about the infection. It is not a protective marker. So you just look for exposure to infection by antibody. You confirm the ongoing infection by doing an RNA or an alternate test like HCV antigen. If you have validated and established, you can do. And any viral load or antigen positivity, you should start with the DAA. And once you give the courses for 12 weeks and 24 weeks, depending on the liver status, then wait for 12 weeks and then do an SVR12 by doing an RNA test. If the RNA is negative, you declare the patient hepatitis C free of infection. Next. These are the drugs which are available under the national program. This I have taken from our national program guidelines. So you have SOF and DECLA. These are direct acting antivirals. These antivirals act on the different region of the virus. Bevirs are the antivirals which act on the NS5B region of the virus, and asavirs are the drugs which act on the NS5A region. We normally give a combination of two drugs. So SOF, DECLA, SOF, Belpa, these are the two combinations usually preferred for, but if there is cirrhosis and decompensation, then ribavirin can also be added. The newer drugs have also come into the market, like some previrs like voxilaprevir and a combined pill Vosivi, which is voxilaprevir, sofosbuvir and declatasvir. But these are unfortunately not included in the program. But for gastroenterologists, there are new drugs also available. And this is how the duration of the treatment is there. Next. And then the follow-up, as I've said, is done only after 12 weeks of stoppage of the treatment. And then you look for RNA. If there is RNA negative, then you just send the patient. At present in the program, the recommendation for genotyping and drug resistance is not there. But those who fail, that is, they do not attain SVR, which is less than 4%, there the genotyping and drug resistance status is done, and for that the sample has to be sent for the Center of Excellence or any higher virological lab in your state. Next. So right now our hepatitis C guidelines are only for adult more than 18 years. Last year on this day, only 28th of July, the WHO released the guidelines where the children and adolescents were included. Now, they have said that there is a good evidence that 12 to 17 years with a strong evidence can be treated by the available drug combination like Velpa, Sofdecla, and Glicopravir and Pebrentasvir are the newer DAA, which they recommend. Then for 12 to 6 to 11, also the strong recommendation. However, 3 to 5 years of age, they say that it has to be conditional. Normally, what you do is that you wait for the children to become 12-year-old or 6 years old, and then you start the treatment if you find infection in a child. But then if you require, then Glicopravir and Pebrentasvir, these are the drugs. So these are very latest WHO guidelines. Indian National Viral Hepatitis Control Program has yet not adopted these into their regime. So our HCV treatment guidelines is only for more than 18 years and above. Next. So the program proposes that if a person comes and is diagnosed with jaundice, so jaundice we are calling it when all ALT, AST are more than 2 times the upper limit, and there is a definite high level of bilirubin. In that case, apart from B and C, the national program advises you that you can also do AIGM and EIGM so that the information about acute A and E can be collected. Next. But if the patient does not have clear-cut jaundice, HCV RNA and serotic workup should be done. And then you can treat these B and C. For A and E, just diagnostic is done, and then the other management is not included. Next. So this is about next. So there are a lot of challenges. So we have launched it. Now, what are the challenges? So it's very good. We should be able to clear the control these infections, but the uptake is not that good. The State Health Mission has to really tighten up their gears and make good model treatment center, good viral testing sites, so that the testing services is offered and patients are not lost to follow-up, because we often see that patients get their serology test done and they never come up for a viral load. Or another important challenge is that supportive and pre-treatment investigation. So the gastroenterologist in my institute, I think Dr. Ashok is here, would agree that they also require an ultrasound abdomen, they also require a hemogram, they also require LFT, and sometimes HbA1c for sugar workup. Those cost of these treatments are not free under the program. Then private sector is not at all involved right now it's only a public sector, and a huge chunk of BNC patients, they go to private sector and take treatment. Then if you are, so very clean BNC is very rarely seen these days. Everybody has got some complication, diabetes, kidney disease, hypertension, or cirrhosis, or fatty liver, NASH, NFLD, all these. So that component is not there. Here, there is a program, we only are giving BNC treatment free. Now, if the clinician says that I also would like to correct the fatty liver, all the diabetes, those tests are not offered free. Then if the patient requires a liver transplant, then in the government sector, the liver transplant facilities are limited. So these are few challenges that India is facing, and I'm sure in the coming years, we would be able to take care of them and upgrade our program. Next. So what we need to do is that right now the awareness should be created amongst everyone that find the cases, and especially the general population, because if a person has got jaundice, that means the liver is already coming onto the damaged state. So we want to catch them when the liver is naive, the liver is clean, and so that the treatment can be offered. So find cases, link them to care and treat them. We did a small study in Delhi. Next, under the UNITED, which was funded by WHO and Find India. And we wanted to see that how decentralized and simplified HCV care can help you, whether we can attain HCV elimination or not. Next. This was a hub and spoke decentralized testing. We got 15 polyclinics attached to us. 5 major hospitals and 15 polyclinics. And what we were doing was we were screening for HCV there, collecting samples, doing RNA at ILBS, and immediately by email sending report. Physicians in these major hospitals were given free drugs, and they used to start patients on drugs. Next, that is HCV treatment. And we could, like, there are 11 districts in Delhi, and we spread the network across all the districts in Delhi. Next. And you'll be happy to see that we actually enrolled 38,000 patients, and we could offer an RNA test to 91%. Although the COVID pandemic struck and we were not able to continue, but we could give treatment to 80% of them and attain SVR. So if you just combine a central lab and connect them to the peripheral lab in your state, you're able to screen so many and give treatment to so many, rather than capacitating all the peripheral labs with an RT-PCR instrument and the challenges they face. And so this is one strategy, and we presented to Delhi government, and we are still waiting if they approve that this can be enrolled in the Delhi state. Next. So what we found was that one should have, if you really want to work on this national program, is one stop for all. You have to capacitate that hospital with diagnostics, with screening, RNA, treatment, and follow-up facility if you really want the patient to be retained in the cascade of care. And that is why we should have very good hospitals where this national hospitals like AIIMS should be capacitated in all the districts and states, where all things are provided on one site. Next. Even the next site, the cost of coming to the patient can also be substantially reduced if you provide all the facilities under one site. Next. So I would like to summarize that we have launched a national viral hepatitis control program 2018, but there are a lot of challenges. At present, the enrollment is that there are 63, most of the states, I think 28 states have enrolled it, and 63 there are treatment sites, and 915 model treatment centers are 63, and 915 treatment sites. So it's doing wonders. At least testing is being offered and treatment is being offered, and it's available. They have also recently integrated it with National AIDS control program. So whosoever is coming at these NACO sites, they are also offered a screening for B and C. But what we need to do is awareness regarding this program, the diagnostics and uptake in the general population before the liver is damaged, so that the clearance of the virus is very, very effective. Next. This is how it has been integrated with the National AIDS Control. So all those which are ICTCs or have taken a NACO facility, they can actually get enrolled by default into the National Viral Hepatitis Control Program. Next. So I thank you, and I am again sorry I took a longer time, and I encourage you that you have microbiology students to come for hepatic and transplant virology PTCC courses. Thank you, Abhishek. Thank you so much.
Thank you so much, ma'am. It was a very nice and crisp presentation, and many a doubt of our delegates, it has been cleared, and it was a proud privilege for me and for our department, ma'am. And as soon as I said to my HOD sir, Colonel Agarwal, he was like, at one go he said yes, and we should bring you for this session, ma'am. Ma'am, there are a few questions for you actually.
Yeah, please go ahead.
Why antivirals to treat hepatitis C are called directly acting antivirals?
They act directly onto the region of the virus. So earlier the treatment was interferon. Interferon was not acting on any of the site of the virus. It was killing the whole cell. It was viral clearance. So the direct acting antivirals I told you are protease inhibitor, Asavir, which starts with prevers like voxeloprevers and other prevers, boceprevers and all. Asavirs are those which act on the NS5A region of the virus, Asavirs, Taclatasvir, Velpatasvirs. And then you have buvers, BUV, sofosbuvir, which acts on the NS5B region. Now, these this is the game changer. That is why the world is moving towards Hepatitis C elimination, that these viruses directly prevent the viral replication, they damage the RNA totally. So we call them direct antivirals, because the other treatment is interferon, which is not acting on the virus.
Ma'am, one more question is, can a HCV person be a donor after RNA is negative?
This was good, because right now the guidelines, the blood donation guidelines have not involved this, but once a person is cleared from the body in the form of HCV RNA negative after demonstrating complete 12-week course and 12-week SVR12, becomes virus free, because the HCV virus does not integrate, but the antibody to it persists for a long time. Now, unfortunately, the blood bank guidelines are not updated. They look only for antibody serological testing. So they right now it is not being allowed if you are antibody positive they are refused from donating blood. I'm also hoping for that some changes should come, but one has to prove that no trace of the virus continues. The another important issue in this is that usually we see the problem of reinfection and relapse in HCV cases in few of them. So despite attaining SVR, because if they are not, if they are IVDUs and all, they get reinfected. So treatment does not ensure protection from reinfection. So chances are very high, if the lifestyle does not change, that they will acquire yet another infection. That is why also we prevent them from donating blood.
Ma'am, one last question. What is the recommendation for vaccination in non-responders, and what is the post-exposure prophylaxis in hepatitis C?
So non-responder for hepatitis B. So hepatitis B, we give 3 doses, 0, 1 and 6 months, and which gives you a good protection. And you should look for anti-HBs immunological response against the virus after 3 to 4 weeks post-vaccination. And if your anti-HBs titer is more than 10, we call it responder. Even if you have given one complete series of vaccination and again a complete series, you do not acquire more than 10, we call it a non-responder. So in a non-responder, ideally you have to take all the universal health precaution. Since you are a non-responder, you're not. One approach is they have seen is that they give the vaccination with some immune adjuvants like GMCF. They increase the dose and give it. The other is that we just give precaution and advisory to the healthcare worker not to be involved in high risk in intervention procedures and take care, because since they are non-responder, they need immunoglobulin administration. For hepatitis C post-exposure, there is nothing as post-exposure hepatitis C treatment. Only thing is we wait for the patient to get infected and then we treat HCV infection. So once a person is exposed, we just, if from a high risk source, then you do an RNA in 15 days, RNA negative, you do an antibody at 4 weeks, then you, if negative, then 6 months following exposure to 1 year to know that no exposure has taken place. Anytime in 1 year you feel that the exposure of HCV has come, like antibody positive or RNA, you immediately give DAA for 12 weeks and treat the post exposure virus. So we treat. So there is no prophylaxis, we treat.
Ma'am, one question from Sumit sir. This will be the last question.
Okay.
Dr. Sumit Rai sir, he has asked the question that how frequently do you encounter the non-responders?
Very less. If the in our institute, I think less than 0.5% of overall healthcare workers in the last 15 years. So it's a very good vaccine, and usually it's very immunogenic, and gives you a very good immune response. You have to be either you are hepatitis B infected and you don't know that you are there, but usually with the strategies like giving an immunoadjuvant or increasing the dose, you get the immune response. So, but yes, there are non-responders which are reported, and we have also seen in our institute also.
Thank you, ma'am. Thank you so much. And I really thank you once again, because from morning you have been traveling to Bhopal, then you had lecture in KGMC. Now after our lecture, you will be again delivering for WHO. Thank you so much, ma'am. It was a very nice session, ma'am.
Thank you. And I'm again sorry for the electronic glitch, because
No, it's okay.
I'm not at my domain. I'm in a guest house. So thank you so much, Abhishek, and best of
Thank you,
luck.
ma'am.
Best of luck to you.
Thank you, ma'am. Thank you so much. Okay.
Okay, so on moving forward, I would like to introduce all with Hepatology and Liver Transplant, Institute of Liver and Biliary Sciences, New Delhi, India. His area of interest are liver transplant, hepatocellular carcinoma, and liver failure. He has 126 publications with H-index 27 to his credit. He is academic editor in many global and translational hepatology, World Journal of Gastroenterology, and Hepatology Forum. His in Clear Global Study and EBCOLI study in EPSL SCLF Research Consortium. He has received various awards and honors from many prestigious like EPSL and ASLD. Over to you, sir.
Thank you for the nice introduction. At the outset, all the as our dear student from IIMS who is organizing, which is all efforts. Most important thing that today the webinars. So webinars is very much people get bored, and at the same time, I got a very difficult topic in the terms of this is a huge. I can say it is a 6 seminar topics has been clubbed to the one. So I just want to say what are the initiatives on various liver societies for the hepatitis management, in particular viral hepatitis, and we'll go in two sections for hepatitis B and hepatitis C. I think you are able to see the questions. This is my pre-test questions for you, and hope after this talk is over, you are able to answer. So I'm not going through now, and at the end we'll go, and I can appreciate that you have learned something after this session. So this is for the Hep C. So I have nothing to disclose, and I think everybody aware of this hepatitis in rough is A to E, the 5 fingers. So now let's come to the hepatitis B. So hepatitis B is a global problem, and at the same time, India is also struggling the same. And we have a percentage of 2 to 4% population. I think Professor Agarwal has already told, and it is means it is a huge burden. You can say 6 crores, and every year we are adding around 10 lakhs per year newborn babies. So just want to highlight to you that what is the meaning of the various terms we use. You can see here, these are the terms we called it as infection when it is HPSAG positive and DNA is positive. If the virus is replicating, that means it's E positive, DNA is very high, and IgM is negative 4. And a person is exposed when we say that he is having 4 antibody IgG is present, anti-E antibody is present, and anti-HS titer is present. That means he has been exposed at some point of time to this virus. And when only isolated anti-HS titer is positive, then he is protected. So these are the very commonly used terms, so dear friends. For you, these terms to remember for as far as hepatitis B is concerned, because we will cover most of the topics on this way. Most important thing that we very often write the word carrier. So just to see that there is no term of carrier, because those having concept to be carrier, they develop disease, they progress. So as a carrier, they should not be harmed, but it's not like that. Hence, the term has been changed to chronic hepatitis B infections. So you write in your prescriptions or suggestions to be chronic hepatitis B reactivation or acute hepatitis B or reactivation of chronic hepatitis B. This is should be the diagnosis in the prescription. And whenever write a chronic hepatitis B, the first I would mention is perinatal or progenital transmission. T is having E plus or E minus, that is E antigen wild or mutant variant. DNA is how much? If we are doing the quantitative HBsAg to be there, ALT is normal or raised, then raised is called as persistently raised or internally raised IRALT or PRALT. And fibrosis, if it has been established either in LSM or in biopsy or surrogates like CT scan. So this is a complete prescription for you when we see a hepatitis B patient in these terms. And most important, don't write. I have also we are getting reference that is carriers, not claim. Then what is the goal of patients to be treated? So these patients to be treated is to get an improvement in quality of life, prevent disease progression, development of hepatocellular carcinoma, to prevent mother-to-child transmission, prevent hepatitis B reactivation, and to prevent and treat the hepatitis B related extrahepatic manifestations. And this leads to long-term remission or suppression of hepatitis virus DNA. If we are able to make a HbS loss, we can able to do ALT normal, and the optimal is we should need a HbSAg loss, surface antigen loss, along with seroconversion, that is anti-HbS should be positive. So this is the goal of a hepatitis B patient who needs to be treated by you. That we have to let that at first the DNA should be negative, then he should get the seroconversion as far as E antigen is considered. Then at the last should be we should get a HbSAg loss with seroconversion. Then important comes because of see that once hepatitis B has been started and treated, they continue lifelong, because the cure is 2 types. One is clinical cure, that is viral load is negative, HbSAg is negative, anti-HbS is low, but the risk of disease is there. So what we think that is HbS is negative, they have a course at silently being HBV DNA negative, HbS negative also can persist. So that is why the goal is absolute cure or the eradication. It should be HbS not at all, that is one of the parameter, but also we need that anti-HbS should be there, close circular DNA should be negative, and because these people are then become negligible risk of SCC, they have least chance for reactivation, the least chance or they are compared to normal person as far as HBV related disease events are concerned. So when you combine all the things, the ideal goal is absolute cure or hepatitis B eradication, which is still a dream and has not been able to address in our research scenario till now, and this is an unmet need. So now, friends, you tell who you are going to do screening, because we see a lot of patients but we don't know how to go for, because universal screening is ideal, but it is lacking. As a clinicians, you are here, you are going to see the patients, you are seeing the people surrounding whom you should advise. So you can see there's a long list, but I just want to highlight that those having HLT is highlighted, enlarged, but they are not able to find any cause, having any chronic disease, particularly sick patients on dialysis, all pregnant women, all infants born to mother, persons with chronic disease, HIV, and the list is going on. So here you have to remember that all this list, because sake of time I don't want to consider. So ideal is to go for universal, but most of the people you should consider. And then if you consider epidemiologically, India's prevalence is close to 4%. Hence, we need to consider all persons born in the country in these groups, and our India and Asia is coming up in this group. That means that universal should be screening. So our goal should be having universal screening. So just to remember the indication, particular, specific, or whenever come across even HBCG screening for them. So screening is to be done as much as, because we say that that's, the theme of this year, the similarity. So what is a screening test? The screening test, most of people do the HBCG. That is wrong. We have to do HBCG along with anti-HBs type. These are the more commonly used. And anti-HB core antibodies we do, particularly who are having HIV, HC, immunotherapy, renal dialysis, or organ donation. But as we are interns, internal medicine specialists, surgeons and gastroenterologists, oncologists, the expansion domain is now to consider anti-HB 3. So just for you, remember these three things to be done. One is HBsAg, one is anti-HBs titer, and one is anti-core antibody total antibodies. So this is needed for all the groups to know that whether this person is infected, occult, or they have been protected. So this is why you need all the three tests to be done at the group. So most important is the hepatitis B can be cause of acute infection. Yes, it can be. Acute infection is happening most commonly, becomes silent because they are asymptomatic, and 90% of these people they get cleared of this, and then only 5% they get progressive. And this progression depends upon the background of liver disease. If it is normal liver, they may get acute liver injury or ALF. If it is a chronic background of liver disease, the problem SLR or decompensated disease. So acute hepatitis B is mostly a self-limiting disease. 90% don't need therapies, and hence these people just need a close monitoring, no need of treatment. So only thing their problem is that whenever we tell that it is acute, particularly in adults, they may have an underlying chronic. So we have to exclude this, and for this we need a definite history of exposure. If there is blood transfusion happened, a sexual intercourse has happened, if needle prick has happened at different time interval, that kind of temporal relationship is there, the duration of treatment is you don't know or is very short, and there needs to be considered. And this group of peoples, the treatment is very limited durations and limited conditions like severe acute hepatitis B, coagulopathy, prolonged jaundice, long duration treatment, then only need treatment. Otherwise, the patients they cure over the time, they got viral loss and they get recovered the liver function. So acute hepatitis B is difficult to diagnose. If it is acute, we don't need to treat unless it is severe course and they need a follow-up. Then whom to treat in cases of hepatitis B you are getting. Remember, all cirrhosis, compensated or decompensated, has to be treated without any confusion. Those having reactivation of chronic hepatitis B in a background of chronic disease, they need a treatment without any confusion. Now comes to a few the patients who are having chronic hepatitis B, and this chronic hepatitis B is without cirrhosis, with fibrosis. Then we need to follow this algorithm, which includes three things to be considered. That is DNA. Then this is to be considered the enzymes. Then to consider the fibrosis. So just remember three things: the viral load, the viral injury-related markers, that is enzymes, particularly ALT, and presence of fibrosis. These things is defined to be considered for the treatment. So treatment is needed when there is DNA is low, ALT is normal. Just we need follow. If DNA is below 20,000, ALT is raised, and there is fibrosis, you need to treat. If DNA is definitely high for that 20,000 has to be treated. And this, in case of E positive, the treatment duration is defined, and we'll come to next when and how long. In case of HPE antigen is negative, we need to the similar way, only the duration of treatment will be considered depending upon the virus positive. So now, as we know that we need to treat definite cases, we need to give definite regimen as per E antigen positive or negative. Then what are the drugs available? We can see this slide. We have two groups of drugs. One is immunomodulation, another is virus suppression. The viral suppression is achieved by nucleoside and nucleotide analogs, the various words you can know, and the immunomodulation is given by the interferon group of the drug. So the drugs commonly used are the three, as you can see here, the entecavir, tenofovir, and the tenofovir is two groups. One is tenofovir, this TDF, and this alpenomide is TAF. So when these drugs are considered to be the high barrier to resistance development, hence considered to be continued. And these drugs should be considered as monotherapy. And the previous group of drugs, like what you are reading the books, lamivudine, adipavir, teludine, has been to be avoided because they develop resistance very often. So because only three drugs are available, that is entecavir and tenofovir. Tenofovir is two drugs that were coming here. One is TDF, which comes as 300 milligrams as a drug form, that is the prodrug, and active form is the TAF, that is 25 milligrams. Then whom to choose among these drugs? Entecavir and alpenomide, that is TAF, should be preferred in those people more than 60 years of age who are having some bone disease, because the TDF has risk of developing or worsening osteoporosis, and in patients with renal problem. So just remember, if you are getting an elderly person, if you are finding a person with osteoporosis and evaluation, or he is having a low GFR or a renal impairment, this group of people should be considered for the alpenomide drug or entecavir for this group of the drugs. Then, when we are giving treatment, how these people should be monitored, because these people are there. Once the treatment started with the nucleic acid analogs, they need performance for first year 3 to 4 months. Then subsequently every 6 months, we need an ALT, HBV DNA, and if fibrosis is there, we need to assess the non-invasive serial fibrosis. So this is to be continued, and then at least 6 months to yearly once for the lifelong, as long as these patients are on treatment. As we discuss the treatment, now we have to say how long we should give the treatment. As I write, divided on the E antigen basis. If a person is E antigen positive, then we need to consider 1 year minimum and 3 years after being undetectable DNA or anything. If E antigen is negative, there is no endpoint to consider. However, it is considered that it is to be given only the drugs as far as the DNA is negative, and then it should be considered only new subsequently, and the aim should be the HbA1c loss and seroconversion. And in persons of cirrhosis, there is no question of defend the time. As long as the patient survives, we have to continue. If we are giving interferon, because interferon is a costly drug, side effects are more prone and poorly tolerated by the patients. In E antigen, we consider for the 24 weeks. If we are going for genotype, then we have to consider the declining HbA1c level, DNA reduction has to be considered. So just remember, it should be duration is 24 weeks and can be extended up to 52 weeks. And most important, I will discuss that many people, if a DNA is negative, then stops medicine. That is not the rule. And if it is done accidentally without having a proper evaluation, then few patients may get survive if there are low risk of relapse. But what happens when we stop the antiviral without having properly evaluated as a potential candidate to stop the drugs? Then there is a rebound increase. You can say the chronic becomes an acute. There is sudden flare of this hepatitis, which can lead to liver failure, development of SLF-like conditions, may be life-threatening. So, to be considered stoppage, it should be done by experts, not like you. Then we have to few markers. If HbA1c, that is quantitative surface antigen level is low, long duration treatment is already received, lower DNA when they started the treatments, and if you have done a good research laboratory, you have done pre-cardiovascular promoters neutrals are negative, then only we can stop these drugs. So dear friends, don't need to go into these difficulties. So you have to consider hepatitis B patient to be treated indefinitely as far as DNA is negative, has no value, because it needs to see a lot of things, E, S, anti-S, and fibrosis, duration of therapy, and the risk group. So just see that these people should continue the drugs as far as you have not the expertise, then please continue the drugs. So what we do, nucleoside analysis should be discontinued only after HBs is lost with seroconversion is achieved. This can be considered if it is negative and more than 12 years of constitution therapy has been achieved, may be discontinued in E-negative patients in absence cirrhosis who has achieved at least 3 years of negativity. And this should not be considered for the cirrhosis patients or patients who have been transplanted. Then when you go to the drugs, the risk of resistance is there. You can see this is a chart of the drugs, how they develop antiviral resistance. The two drugs we discussed, that is tenofovir or entecavir, has resistance even up to 6 years is very less, even tenofovir up to 8 years is 0. Hence, this is considered the drugs with the high barrier for the resistance, and the other group of drugs has been obsolete and has been removed for the market, and only available now is the tenofovir or entecavir for the treatment. Then, important is the resistance. If one develops resistance, how to manage this group of people? The LAM resistance should be considered switching to the TDF. If telvovir to TDF, entecavir to consider to the TAF, and other drugs definitely we are not using, but we have concept to use the high generation drugs. However, as we discussed, the treatment with this duration needs to be considered for a long term. HPCG loss is very low, less than 4%. And when consider these drugs, we need to know the duration of combination of therapies. And hence, the various proposal to consider two drugs has not been recommended by any society. In the nukes group, even also combination of nukes with interferon has not been supported by evidences to do. So hence, dear friends, these patients should be continued drugs indefinitely. You have to do the monitoring as far as these enzymes, DNA, especially is concerned, and then you have to see that how they can be done. So now, when we are able to treat the HBs positive patients, now we consider how to manage in special situations. The most common, as we have discussed, is the hepatitis B during pregnancy. The hepatitis pregnancy transfer from mother to baby happens in prenatal phase, in a natal phase, and postnatal. The most natal is the during the delivery, and little bit happens in utero, that is prenatal, and very limited risk is 5 to 10% postpartum transmission. So, dear friends, most common is delivery. Near to delivery is the major period of transmission. And the drugs, you have to remember which drug is safe. You can see the FDA category. They have recommended two drugs, that is tenofovir and telvovir as the B. However, telvovir has been withdrawn in the market. So most preferred drug for the pregnancy is to be considered is the tenofovir. So any person of pregnancy is continuing on another drugs, may be switched of the tenofovir. And then if a newly detected, how to treat, we'll discuss in the first slide. So deciding the treatment for this pregnant lady needs to consider drug safety, drug resistance profile, which drug we preferred as we discussed tenofovir, and benefit and risk should be explained to the relatives. So what we do when I see a lady pregnant to us, all pregnant women should be screened for HBsAg. Those who need standard criteria, as we have discussed, they should be treated. If those not fitting the standard criteria, then the next aim is to prevent mother to baby transmission. Transmission needs depends on the high viral load. There is a relationship between high viral load, high chance of transmission. So the ideal is to start the treatment with third trimester and continue the treatment at least 4 weeks to 6 months postpartum. If the DNA load is very high, then we can start the treatment in second trimester, because first trimester is the period of organogenesis, transfer risk is minimum, so we can defer during this period. However, if it's a known case of cirrhosis or those who have been on therapy, they have to continue during the pregnancy. And remember that as your doctor, you are advising patients that all hospital hepatitis B mothers should be delivered in an institutional setup. And whenever they will deliver the baby, they need to get the babies immediately dual regimen of HB, that is hepatitis B immunoglobulin, along with HB vaccines to be started within 12 hours. And the chance, as you discussed, the postpartum transfer is there 5 to 10%. However, this has been not considered as a contraindication to be feeding the baby. So the breastfeeding is also not contraindicated for this. So this is in nutshell for the pregnant lady you come across to manage his hepatitis B spectrum. Then comes some other special groups is the children. So in children, the treatment should be considered in presence of fibrosis, high viral load, as we discussed that who are like the elder, that we have the standard treatment, the standard regimen. And the children should consider the drugs are the same as the adults. Now coming to us, as a healthcare worker, if someone is having hepatitis B or someone is prone to hepatitis B, so HPV election should not be considered disqualified from work. This is a major practice in many centers, not in India, abroad, that if a person is working in the field of medicine to be considered to be debarred. This is a very practical thing for you, that we need all should be tested, we should get vaccinated, and we should check our antiviral titers regularly, so when the assay to prevent ourselves. But if we are infected, how to do? Their suggestions is that you try to less involved in the risk prone, contamination prone, injury prone professions. So some area of a doctor, a nurse, or a paramedic who is working in the lab where bricks are required, he may shift to the OPD basis. So this is how you have to do the adjustments. And then they need treatment. This preferential treatment should be given that they can resume their job if the DNA is below 3 logs. And this is without treatment, or if it's on treatment, then it should come down below 3. They should consider the routine activity. So just this is a food for thought for every one of you, that any health related personnel, the healthcare workers having DNA positive or HBsAg should not be debarred from his work in his workplace. Then important is patients who are on immunosuppression therapy. So all patients who are on immunosuppression therapy, they are likely to develop a flare of his hepatitis B. So in this group of patients, this should be tested for HPV prior to immunosuppression. All HBs positive should be treated, there is no confusion. And these people should be considered for the anti-HBs testing. So anti-HB core positive is that the person is exposed. So there is chance of reactivation while he receives the immunosuppressive therapy or cancer chemotherapy. Hence, they should get prophylactic regimen to prevent the flare. So dear friends, all patients who are planning to go for immunosuppression or chemotherapy, they need a testing for this. And then testing includes HBsAg and anti-HB core. And then if it's positive of either of one, they need a treatment for this. This is the take-home message. And then you have to define what are the drugs which are being high risk prone for reactivation, moderate or low risk infections. Then important another is the patients who are on dialysis. We very often see practice the patients are on dialysis, they need a treatment. And these patients who are on dialysis, they need a regular screening for the HPV. If they are on HPV vaccinations, they need monitoring of their titers. If they found positive, they should be treated with drugs as per the standard regimen. If they are being not having infections, they need a prophylaxis if he is going for the transplant. So all patients of the kidney disease, once positive, going for the transplant, then they are likely to get immunosuppressions, hence they need a prophylaxis. Then important is extrahepatic manifestations. As you are aware, hepatitis B patients has developed some changes which are very typically extrahepatic manifestation of hepatitis B, like vasculitis, purpura, polyarteritis nodosa, arthralgia, peripheral neuropathy, glomerulonephritis. So these are the people who are needs to be treated irrespective of the viral loads. So any patient of hepatitis B having extrahepatic manifestation, they need to treat with either nucleic acid groups, and then those patients having immuno-related disease, particularly pulmonary edema and vasculitis, they should not consider interferon because they are immunomodulatory. So just remember that irrespective of viral load, extrahepatic manifestation of hepatitis B, they need treatment, and the treatment is NUCs, that is tenofovir or entecavir. Then important is another co-infections. If hepatitis B is most important is hepatitis D. Hepatitis D is a dependent virus. They correlate or add on this, and the treatment for them is interferon, and this should be continued for at least 1. Then another is the HIV. So when there is HIV in a hepatitis B co-infection, most of the HIV regimen is considered to have the nukes drugs, that is lamivudine and tenofovir. So hence the drugs should consider at least 1 or 2 drugs regimens should be there. Then important is a Hep C co-infection. When there is a Hep C co-infection, these people need to be considered to be treated with hepatitis C drugs along with hepatitis B drugs or to prevent the hepatitis C related immunodestruction leading to the hepatitis B reactivity. So most important now that we know the special situations where hepatitis B should be treated and how we are going to support the people who lives with hepatitis B and how we can prevent vaccination. So these hepatitis B peoples are not immune to the other injuries. Hence, they should consider alcohol to be abstinent or minimize. They need hepatitis A vaccination and they need not to have developed fatty liver, obesity or metabolic syndrome. And for the transmission, your surrounding area should get vaccinated and definitely try to avoid work for injuries. And universal precaution is the rule, but not to ban these people from a community setting. So most problem in the household is the department, particularly daycare center, school, sports club, camp. So these are the areas where we should not make them bad because they need a normal life. They need to live with a dignity and they should treat with because they are very chance of getting infection are very minimal. Then important is vaccines. I am thinking that we are all medicals sitting here, so most may be vaccinated. If not, we have to go for HPV vaccine is considered now universal vaccine. India is covering all newborns with this program. And as we discussed, any sexual or household contacts in your surrounding, if anyone in the family is having hepatitis, we should treat everyone. Newborn, as we already discussed, they should need treatment rightly. And anti-HBs titer is needed to be tested to know the efficacy of your vaccines. This is not needed routinely, but particularly who are prone for these infections, that is like our healthcare workers, disease people, chronic infections, those need immunosuppressions. And important is another group where infection chance is more than the vaccinations, so we need to test them. Then we know the vaccine dose, I think I'm not going to say, but as you are going to write a prescription, remember the dose is 3, that is 0, 1 and 6 months, that is standard. Now it is comes with combination with the hepatitis A vaccines. So this is interesting that hepatitis A and B are mixed to just give dual protections. 2 index vaccine, the dose is 0, 7, 21, 30 days, then another at 1 year. And now recently, because of many people get defaulted with the hepatitis C vaccine at 0 and 1 months, and particularly at 6 months. So now new vaccine variant has come with having 2 doses only 0 and 1. Vaccine efficacy that we told that anti-titer needed to be done in limited group of patients. If you find that your vaccine is not working, then how to go for? We need repeat double dose and the dose should be doubled. Booster dose, as you rightly think that if my titer is below 10, whether I should take or no, we need to take, particularly if you are a healthcare worker, hemodialysis, immunocompromised, or a baby born to the HBsAg positive mother. So dear friends, you all being a medico, you advise to this to your all concerned patients, but at the same you get tested of your titers. If it's below 10, we need a vaccinations, and the vaccination should be a repeat dose of vaccinations. And if you remember that this vaccine is taken less than 10 years before, that means the vaccine is failure, then we need to take double the dose and 3 doses to be considered. And this vaccine is the only weapon in hepatitis B which prevents liver disease, which prevents complications, which prevents cirrhosis, which prevents SCC. The burning example is the 30-year follow of the Taiwan study, which is highly potent and everywhere. Then next important is a person hepatitis B, how to go for SCC. SCC is the most dreaded risk in this group of patients. We need to consider that these people, if they have a cirrhosis, if his E antigen is persistently positive, if genotype is C, and if they have a high viral load, and this viral load is remain for a long time, they are a person who are at risk of hepatitis B related SCC, they need monitoring. And this is very interesting. You can see that if hepatitis B is happening, as the duration of disease goes, the risk increase. Suppose if you see a patient of hepatitis B, he may not develop cirrhosis, SCC till 30 years, but soon after 30 years in long term, they have become very much prone to develop SCC as well as recurrence of SCC. Hence, the guidelines across the globe is to treat 6 monthly with ultrasound and ultrasound therapy. As far as the various societies in Asia, in India, we consider ultrasound and alpha fetoprotein 6 monthly as the surveillance for all hepatitis B for SCC. Then who should be considered for this screening? All patients of cirrhosis should be considered. All hepatitis B, as we discussed, at the high risk group should be screened, and children who are having advanced fibrosis or anyone in the family having SCC should be screened for the SCC, and this should keep under surveillance. So now, dear friends, I hope we have covered. We know the goal of therapy is HBsAg loss with anti-HBs positive. We need universal screening, which is an ideal. Acute viral infections we need to treat if it is prolonged, protracted course or liver pylori OC. 90% get cured. Then we know that treatment is decided on 3 things, that is DNA, ALT level, fibrosis. Then when we treat these people, so we need to monitor their treatment response on the terms of DNA, E antigen, enzymes, HBsAg loss. Then treatment is very simple. 3 drugs we have to remember, that is entecavir, tenofovir, alfenamide, tenofovir discovir. And the treatment stoppage should be considered by a specialist. That is when we know specific parameters will made. Otherwise, you continue the drugs till early. If its treatment is failure, we need to develop for the resistance profiles. And combination therapy is not recommended at the point of time. And the pregnancy, that is the most common you have to see. So in pregnancy, we need to, those on treatment should continue the drug. Tenofovir is the safest drug, and the treatment should start at 3rd week. We may start at 2 weeks if it is a very high load, more than 6 logs, and all children born should be vaccinated within 12 hours with a dual regimen, that is HB along with the vaccine. Children's, if justified like the adult data, they should be treated. Healthcare workers like us, we need to screen ourselves. We need to vaccinate ourselves. We need to check our anti-HB titers should be more than 10. If no, we need to get a dose of booster. The patients immunosuppression, dialysis, and extrahepatic, they need special monitoring. Extrahepatic monitoring, they need treatment. And co-infection should be addressed. And HBV infection is the main thing for all this prevent. Discuss what we discussed, and for this you need to treat them with this care. As we covered the hepatitis B, now we'll go to hepatitis C. I know it is big topic, it may be boring, but I am trying to justify as much as possible. So, dear friends, when you see hepatitis C, we need these following questions. Should I treat? Should I do biopsy? And all the things I am coming one by one. And I hope at the end we will be able to answer these are the practical questions what we are going to see when you see a patient of hepatitis B or treated, you are followed and you get clear. And no doubt, I am not going to epidemiology, but hepatitis C is also another big challenge for India as well as the world. India is affected. However, with the highly effective drugs, which is the future in hepatitis B, the hepatitis C has achieved this drug to cure this, and now this has gone to be elimination range by 2030 as WHO suggested for us. And this hepatitis B needs, because it is also a major cause for mortality, morbidity, related to cirrhosis and SCC. So how to go for, as you know, it is the reverse of hepatitis B. In hepatitis B, 90% get result, 5 to 10% gets only chronicity. Whereas in acute, nearly 55 to 85% develop chronicity. And also that is depends on the age of acquire, below 30 or more than 30 years. And they develop decompensation over the periods, and SCC develops 3% per year. And you see the burden in India. It is still unexplored, still needs to be find them to treat them. And when you consider these peoples to be considered, how to diagnose them. The hepatitis C treatment for HCV patient diagnosis needs under 2 things. Anti-HCV just suggests that this person has a exposure to hepatitis C. Because once positive, this anti-HB virus HCV antibody will remain lifelong or at least minimum more than 10 years. So don't get panic with anti-HCV positivity. You have to go to the HCV RNA level. If the HCV RNA is positive, then it is an acute infection. You can see here, anti-HCV positive, RNA positive, it may be chronic or acute. If anti-HCV positive and RNA is negative, that means he has been get cured either by therapy or spontaneously. If anti-HCV is negative and RNA is positive, that means it is the very early phase where the infection is evolving, not able to mount the antibody. If both is negative, that means it's pure negative. So this is a slide for you to feed friends to see that anti-HCV and HCV RNA needed to diagnose hepatitis C. Then whom to treat is not like hepatitis B. Hepatitis C, all patients should be treated without any confusion. Only patients which may be considered not to be treated if they are younger, if they are pregnant, if the survival is very less than 6 months, particularly when there is advanced liver disease, advanced SCC because of Hep C, they may not be given. Otherwise, most patients need to be treated with hepatitis C drug. Then treatment needs 3 things to be considered: genotype, fibrosis, decompensation. This will make your decision for these people to be considered for their treatment. So if genotype 3, they are resistant variety, cirrhosis, they need to know how they are going to behave. Drugs, it may be safe or may not safe when a decompensation are there. So this is, we know how to know, access the severity is a history, physical examination, clinical, fibroscan, endoscopy needed. Do we need biopsy? The biopsy is not needed per se for an hepatitis C. We need only when there is a mixed infections. You think of something beyond hepatitis C, like fatty liver, alcohol, autoimmune, DILI, and other conditions. But the time has changed. Now we can avoid biopsy, and because now this non-invasive fibrosis testing has come up bigger way. I think, dear friends, you are aware of this fibroscan or transient elastography, which is commonly considered to detect the fibrosis more reliably, more accurately. And this is the fibrosis scan. The value shows against correlation to the fibrosis to the LSM, the stiffness value, that is F2, 7.1 to 8.7, 9.3, 9.5 for the F3, and 12.5 and above F4 or cirrhosis. So this is a very simple test. This is a diagram tutorial. You can see this. However, few conditions, because now patients are coming up the fibroscan report for everyone. So no, you have to know the conditions. Presence of jaundice, ascites, or those having Buerger syndrome, liver tumor, vein blockage, they may have a falsely high value also. So these are conditions which we should avoid. Then consider drugs. This can see the hepatitis C journey is like this, from standard interferon, which is painful, to now very simplistic drugs that has come. This is the viral genome. On the basis of this, the drugs has been made, that is structural, non-structural, and region-wise drugs. And these drugs, the backbone of all therapy is supposed to be, that is NS5B. And then either consider this group of drugs or protease inhibitor group of drugs, and ribavirin is a third on additions. So either supposed to be plus any one of them, or supposed to be plus this plus ribavirin, depending upon the conditions and the exposures and the treatment. And the duration response definition, we are not going to talk to you. It is very difficult, but most of the drugs need to be given for the 12 weeks. If you have taken a drugs, if it has develops, relapse, or non-responder, the first step should be to treat it again for either 3 months or extended duration of treatment. Irrespective of the genotype, the treatment is similar. Then these drugs, they develop resistance, which we are not going to discuss, but whenever you find this, then please send them for a testing for the resistance associated mutations, and then accordingly appropriate drugs can be considered in this group of the patients. Now, as we have seen over the time, the interferon has gone, drugs has now come up, and the drugs are now become the pan-genotyping. Previously, we have to divide the drugs that genotype 1, 4, 2, or genotype 3 to give drugs. But now, mostly one size is going to fit for all, that is supposed to be Veltosbury are going to cover all the drugs. Or supposed to be Veltosbury plus ribavirin is going to consider for all group of cirrhotic patients, irrespective of the genotype. and the response is very good, 90% cure rate, and they cover across the treatment groups. Then importance is, as likely we have discussed, who are the group of special monitoring is needed, particularly if it is an advanced cirrhosis, those are waiting for the transplant. If they are having SCC, they should be considered. And you can see a very interesting diagram. If the MELD goes on the higher side, then the transplant waiting list antiviral therapy going to have less benefit. If you can see, if his MELD is below 16, you got Hep C positive, then 35% may recover and get delisted. If it's 16 to 20, then around 12% may get recovered. Whereas 21, 25, you may treat, but chances of getting delisted is very minimal. So we need to this. Post-transplant, we need to see the people's, they need to be treated with definite period of 6 months. In hepatitis C group of drugs, in India, no approved drugs, but these are the few studies where we find that SOPO and DACLA or SOPO and VELPA, this can be given without having any adverse effects, and they are maintained on dialysis and they are given full dose. Then if you consider in female reproductive age group, they need to be treated. Pregnancy, these drugs are not recommended. This is for you. Remember that in consideration of treatments should not be considered, and they can be treated after the pregnancy. So for you, you have a Hep C patient, you are getting pregnant lady, just advise them assurance, monitor them for the liver functions, and soon after the delivery is happened, you may consider for this giving to this. And the safety is in children is not established, and so it is better to give after 6 months of exclusive breastfeeding. Then when going for the therapies, we need to treat these patients. We have to see the drug-related adverse effects. We have to monitor them. And then next important is the development of SCC. SCC occurs in those having co-infections, alcohol, obesity, diabetes, and special groups are there. And now we have able to cover the Hep C also. So dear friends, now to summarize, all Hep C patients should be treated. That is no confusion. Liver biopsy not needed. You can go only in selected cases where diagnosis of etiology is a dilemma. And then these people should be treated with antiviral. This should be considered. Now the fibroscan has come up in replacement for the biopsy. Genotyping is needed to diagnose the treatment response. However, now we can consider these people's irrespective because pan-genetic drugs has come up now. And SCC, Hep C RNA monitoring is needed at the end of the therapy. Resistance testing is difficult in Indian scenario, costly, limited availability, only done in the research domain. Pregnant patients should be tested for Hep C, but if it is positive, they should not be treated during pregnancy. They have to be completed the at least 6 months post-pattern exclusive breastfeeding period is over to be treated. Decompensated cirrhosis should be treated, but there is a limited data. More than 25 treat or no treat, there is no difference. So we have to consider these drugs to them. If they develop problems, we don't have to continue. And all in hepatitis C, there is chance of having hepatitis B co-infection. When B and C exist, the B is silent, C is dominant. So if we are not able to do the anti-HB4 testing, then after Hep C cure, that may develop resurgence of hepatitis B later reactivation. So anti-HB4 should be done. And all pre-LT SCB RNA can be treated and also direct can be treated. And last, can hepatitis C treated by general practitioner? I think now it is coming out. So simple treatment, drug is fixed dose, duration is fixed for 3 to 6 months. And now this domain has now come from hepatologist or gastrologist to general physician. With this, I want to thank you all. And I request that we have an excellent liver cancer update. If you're not interested, you can join. And also we have a liver cancer online webinar sessions every month, second Tuesday. So this month also, and you can join. Thank you.
Thank you so much, sir. Thank you for this wonderful presentation. We have actually quite a number of questions, sir, but we are running out of time now. We will request you to answer it, and so that we'll send it to the participants through their email.
Okay, sure. Thank you.
Thank you so much, sir. Thank you once again, sir. Start video. Start video.
पहले share screen कर 3:37 again.
Vivek, I think session is over.
Okay, sir.
Session is over.
No. We can continue now.
No, this is the last presentation. This is the last presentation.
Okay.
We have our fourth speaker, Dr. Pragya Agarwal. Dr. Pragya Agarwal is an assistant professor in the Department of Microbiology at AIIMS Raipur. She has done MD in microbiology from CMC Vellore as well as PDCC in hepatovirology from ILBS New Delhi and a diploma RCPAP from London. Notably, she received a gold medal for her academic achievements. She has 19 publications and 247 citations to her credit. She has authored a book chapter and has been actively involved in 5 intramural projects, showcasing her commitment to research and academics. She serves as a reviewer for reputable journals like IJMM and JCDR. Furthermore, she was nominated by AIIMS Raipur as a master trainer entrusted with the responsibility of providing training for COVID-19 testing, highlighting her impact on the front line during the pandemic. Over to you, ma'am.
Thank you. I am trying to share screen, but I just I'll just it is there. I think there is some.
Ma'am, you just go to the share screen option.
Yeah, that's what I'm doing.
Share your screen. Yeah. Ma'am, have you opened your presentation in the background?
Yes, I have.
So you just click on that and then you start sharing your screen.
I think there is some issue. I'll just try once more. Otherwise, I think I have sent you my PPT, Abhishek. You can play from there. Doesn't work.
Ma'am, please try once again. Ma'am, otherwise you send it to me once again. I think I have not received it.
Send to the PPT.
आप फिर से भेज दीजिए मुझे व्हाट्सएप नहीं तो ईमेल व्हाट्सएप कर दीजिए.
You didn't get my mail?
No, you have sent it in your okay.
Will Ashok sir take the answers to his questions? I'll just fix it in a minute. Is my PPT openable from there?
Ma'am, please allow us some moment so we will be able to fix it.
Bus 5 more minutes, ma'am. We'll be starting. Sorry for the delay. Now, ma'am, are you there? Pragya, ma'am? The session is not yet over. The session is very much going on. This is the last presentation.
शेयर कौन कर रहा है?
वो सर इको
प्रज्ञा स्क्रीन is there. So should be working here. You are doing Pragya's screen.
Is the slide visible?
Yeah, yes, ma'am. The slide is very much.
And the slides are changing?
We can start.
Okay, I'm
Slides are not
extremely
changing.
sorry for this
No,
terrible glitch
okay.
which happened and for keeping you all waiting. It will be a difficult task for me to do justice to this after the stalwarts who have presented such wonderful presentations. I will try my best to demystify the acute viral hepatitis scenario A and E conundrum, the task which has been allotted to me. I hope I'm audible and visible and the slides are visible.
Yes, ma'am. Yeah. It is visible.
I'm audible and visible. Can just somebody tell me if I'm
Yes,
audible and visible so that I can continue?
Yeah, you are audible, ma'am. You are very much audible.
Okay. Okay, thank you. All right. Right. So this is the overview of my talk. I'll briefly touch upon the 2,500-year timeline of the hepatitis viruses. I'll talk about hepatitis A viruses, hepatitis A virus, the epidemiology of the virus, the burden of the disease, the vaccine and the paradoxical effect that the vaccine has had, the markers of infection and interpretation of the serological tests. Moving over to hepatitis E virus, I talk about the genotypes, how they are distributed across the globe, how they differ in their modes of transmission, and the epidemiology, the clinical manifestations of the disease, lab diagnosis, the conundrum, drawing parallels between the two viruses, the differences between the two, what are co-infections, and then the unanswered questions and challenges before I conclude. So hepatitis viruses A and E, they serve as bookends for the viral hepatitis, not just in terms of the names, but also in terms of the sequence in which they were identified as distinct entities. Are the slides changing?
Slides are stuck actually, ma'am. They are not
Are my
changing.
slides changing?
No, slides are not changing.
Yes, slide showing here.
You can scroll down. As
I don't
Nitin
know
has said, you
why
can
it
scroll
has
down.
been so.
You just scroll down. Ma'am, you can keep scrolling down. Yeah, it is moving now, ma'am. It is changing. Ma'am, can you hear? It is changing.
I don't know, it has been
No, it is
really
changing.
unfortunate for having so many technical glitches.
No, it's okay.
I believe that my slides are changing now.
Yeah, they are changing. They are changing.
Moving over to hepatitis A virus. We all know that hepatitis A virus is the most common form of acute viral hepatitis that has been recognized globally. And this virus belongs to the genus hepatovirus placed within the Picornaviridae family. It is a positive sense single-stranded RNA virus, just like the hepatitis E virus. And there are 6 genotypes of the virus which are known. Amongst these 6 genotypes 1, 2, and 3 cause human infections, and they have multiple subtypes. 4, 5, and 6 do not have human hosts. In the life cycle of the virus, I just want to emphasize upon 2 points. This virus, as well as the hepatitis E virus, they have 2 forms. One of the form is known as a quasi-enveloped form, which is secreted from the hepatocyte into the blood circulation. The other form is a naked virion form, which is excreted into the feces. So it is secreted into the bile and into the feces. The naked enveloped form is suitable for transmission in the environment, and it is a hardy form that sustains the environmental condition. Whereas the quasi-enveloped form has a pinch of the host membrane around it. So this helps the virus, this provides virus protective immunity from the neutralizing antibodies. Upon acquiring hepatitis A infection, the manifestation depends upon the age of acquisition. In childhood, most of the manifestations are asymptomatic. Recovery is spontaneous. Even the symptomatic infections, most of them recover spontaneously. But then our cause of concern is the acute liver failure, sometimes the extrahepatic complications, and the relapsing hepatitis and prolonged cholestasis, which can happen. Estimating the burden of hepatitis A or E, for that matter, is not easy because a large chunk of these infections is asymptomatic. WHO in its 2019 estimation says that there are more than 100 million HIV infections, and the extent of the extent by which these infections are borne in across the globe depends upon the socioeconomic status of the countries. So most of the burden is borne by the low and middle income countries, and hepatitis A virus is the second largest cause of fulminant viral hepatitis after hepatitis B virus infection. Now, hepatitis B is prevalent, especially in large parts of Asia and Africa, and it has been shown beyond doubt that whenever a superinfection with hepatitis A virus occurs in a hepatitis B positive patient, that leads to a fulminant course. So this is the world map, which shows the epidemiology worldwide, and estimation of seroprevalence can be done by many methods. Seroprevalence can be estimated by having a look at the IgG antibodies, which are prevalent and which are marker of previous infection and exposure. Another way of looking at it is the age standardized incidence rate or the number of cases which are detected. So with that, the age prevalence is the best method of indicating prevalence in hepatitis A. India and large parts of Africa, specifically the sub-Saharan Africa, are regions which are of high endemicity, the Indian subcontinent, I should say. And this is the region where more than 50% of the population become infected by 5 years of age, and almost 80 to 90% of the population becomes infected by 10 years of age. And the transmission in these areas is fecal-oral, rarely parenteral. In the Western world, the scenario is different. In the Western world, it is more of a sporadic disease, and there are certain risk factors which sort of tricks the balance between improving epidemiology in terms of decreasing infection rate, which is happening because of improving socioeconomic status, because of better hygiene, because of safer food supplies, and obviously because of vaccination that is happening. So this is decreasing the prevalence of hepatitis C in a lot of regions, whereas globalization, as in travel from non-endemic to endemic countries where you get the infection upon your travel, or import of frozen food from endemic countries, and high-risk groups like men having sex with men, people who inject drugs. These are certain factors which sort of increase the prevalence of hepatitis A in the non-endemic developed world. When we talk about the Indian scenario, it is very well known that it is the commonest cause of pediatric liver disease in India. In the general population, hepatitis A accounts for 10 to 30%, that means a quarter of cases of acute hepatitis, and almost 1/3 cases of acute liver failure in India. In the pediatric population, this is more. It accounts for almost 3/4 of the cases of acute viral hepatitis, more than 50% cases of acute liver failure, and 1/3 of cases of acute or chronic liver failure. And 80 to 90% of Indian children get infected and acquire antibodies which are protective by the time they turn 10-year-old. However, a change of epidemiology is being reported from large parts of India. There is a shift from high endemicity to intermediate endemicity. Now, this intermediate endemicity has led to increasing infections in adolescents and adults. And when an infection occurs in adolescents and adults, the infection is more often symptomatic, the risk of complications is higher, the risk of hospitalizations is higher. Now, these are two studies. This first study, which was done at Government Medical College, Chandigarh, which has shown that the percentage of adults which have been infected over a period of 8 years, starting from 2011 to 2018, the percentage of adults has been on rise. And this another review is a review of a lot of studies done across the Indian subcontinents, including our neighbors like Pakistan and Bangladesh. And again, the findings have been same that there has been a shift of age group towards adolescents and adults. So this is not a very great thing to have happened. It cannot be put up so simply, because today we are in a very paradoxical situation where India is witnessing an epidemiological transition. Hygiene standards, the socio-economic status, the safety of the food and water supplies has improved in India. But then this improvement has not happened uniformly throughout the country. This improvement has happened in urban areas, not so much in rural areas. And what has happened is, because of this, there are pockets of susceptible population which are scattered between population which is protected. Another factor which has compounded this situation is the low immunization coverage. So we have immunization which is not very, what shall I say, not very uniform. It is very erratic in our country, immunization against hepatitis A, compounded by this irregular distribution of resources across the country. And this has led to not just transition of the age of infection from children to adults or adolescents, I should say. It has also led to change of the disease pattern from an endemic to an epidemic pattern, where outbreaks can occur. And these outbreaks would involve adults and adolescents who are not protected. And when they acquire infection, the severity of disease would be much more. So HAV vaccine is a handy solution to avoid such a scenario. It would not be an overstatement to say that it has been 20 years since the vaccine has been licensed. Probably in 1992, the vaccine got licensed. And this is one of the best, the most immunogenic, well-tolerated and safe vaccine which has ever been made against any virus. There are both inactivated as well as live attenuated vaccines which are available. The inactivated vaccine needs 2 doses, whereas the live attenuated vaccine needs just 1 dose. And both of them have very good immune response. The protective antibody level is reached within 4 weeks of the dose, and it is retained for as long as 50 years. And you should say the duration of protection is lifetime. Now, WHO recommends that universal vaccination against HIV has to be weighed depending upon the endemicity. If a country is in a scenario where the endemicity is declining from a high endemic to an intermediate endemicity, and the incidence of the disease is on a decrease, and if the cost effectiveness is justified, it can be integrated with the national immunization schedule. That has not happened in India, but IAP recommends that vaccination should be given to children after 1 year of age. This is the incidence of hepatitis A in the United States of America. Universal immunization for hepatitis A was recommended in USA in the year 1999. And it can be very clearly seen that cases plummeted soon after the vaccine was implemented. Another success story is from Israel. Israel was in a state where it was transforming from a high endemicity to a medium endemicity in the 1990s. And it was in 1999 when the universal mass vaccination of toddlers was introduced and the cases plummeted hence on. And not just Israel, there are a lot of countries where this has happened. Argentina, China, Uruguay, there are a lot of examples, a lot of success stories for hepatitis A vaccine to have worked wonders. But then it often happens that public health interventions, when successful, they are followed by a sense of complacency. So the same has also happened with hepatitis A, and the virus has re-emerged specifically in adolescents and adults, and it has assumed outbreak proportions. There has been an increase in incidence in the European Union countries, and this chart gives you an idea of the number of hospitalizations that has happened in US ever since for hepatitis A, ever since the vaccine has been licensed. So it causes more of cases in adults and adolescents, and these cases are way more severe than the infection which would have happened if the infection was acquired in childhood. A lot of outbreaks have happened from various parts of the world, and most of them have been attributed to foodstuff and have happened in high-risk groups like MSMs, in illicit drug users, in the homeless population. A lot of outbreaks have also happened in India. However, these outbreaks have been linked to contaminated water supply in most of the instances. This is a display of the laboratory markers that are there in hepatitis A virus infection. Viremia starts much before, even before the onset of clinical illness, and antibodies, anti-HAV IgM and anti-HAV IgG rise thereafter. So it is these three markers that are most commonly used. Anti-HAV IgM is a marker of acute infection. Total anti-HAV, which is a combination of IgM and IgG, is also done in certain settings, specifically the pre-transplant screening. And a total, an anti-HAV IgM positive denotes current infection, and the IgG or the total positivity in the absence of IgM would also mean vaccination, if not a previous infection. So the treatment has to be symptomatic. There are no antivirals which can be used. Even in cases of acute liver failure, interferon has been tried, but there is no consensus upon its use. And although the improvement in sanitation is the cornerstone of changing the epidemiology of the disease, for countries that are as huge as India and as heterogeneous as India, it is not possible to implement such measures on a large basis. So childhood vaccination provides an opportunity to offer long-term, in fact, lifelong protection against hepatitis A. And also certain high-risk groups like chronic liver disease, transplant recipients, and food handlers must be vaccinated in a targeted manner. Moving over to hepatitis E. Hepatitis E, just like hepatitis A, is another important cause of acute viral hepatitis distributed worldwide. It belongs to the genus orthoepivirus within the Hepiviridae family. Like hepatitis A virus, this is also a positive sense single-stranded RNA virus. Just like the hepatitis A virus, this also has two forms, two morphological forms: the naked particle, which is excreted along with the bile into the feces, and the quasi-enveloped form, which is circulating in the blood. Traditionally, hepatitis E has been considered as an acute self-limited disease, which often causes outbreaks or sporadic illness in developing countries. But then there have been entities, newer clinical entities, which are associated with this virus, and that has led to a newfound interest in hepatitis E virus. This Hepiviridae family has a lot of hepatitis viruses, which cause with a very broad host range, which range from mammals to birds to fishes. Infections, strains that infect humans belong to orthoepivirus A. Genotypes 1, 2, 3, and 4 are the genotypes which are responsible for it. Amongst this, genotypes of the hepatitis virus A1 and 2 are the ones which infect only humans, whereas 3 and 4 are zoonotic. So pigs, wild boars, these are the reservoirs for genotype HEV 3 and 4. 5 and 6 are found in wild boars. Transmission to humans has not been documented. 7 and 8 have been identified from camels. And there is a single case report of genotype 7 causing an infection in a human being to a man who was a liver transplant recipient. And in fact, it led to the causation of chronic hepatitis A infection. An understanding of hepatitis E virus genotypes is essential because hepatitis E virus genotype has a significant bearing on the modes of transmission, and they have a very significant distribution across the globe. As is evident from this picture, the Indian subcontinent, in fact, Asia, large parts of Asia, large parts of Africa and Mexico are endemic for HEV 1 and 2, which are the non-zoonotic genotypes. Hepatitis E virus genotype 3 is spread throughout the world, Americas, North Asia, Europe, Australia, whereas China has a very interesting epidemiology in the sense that it was initially hyperendemic for HEV genotype 1, but currently the most prevalent genotypes in China are HEV 3 and 4. And 4, the reservoir host of genotype 4 is swines, and it is a zoonotic infection that is prevalent in China. This is a beautiful description of how genotypes decide the mode of transmission. Genotypes 1 and 2 are human pathogens strictly, and the primary mode of transmission is through contaminated water supplies. And that is how genotype 1 HEV has caused periodic outbreaks in India. There have been outbreaks, there have been sporadic cases. So this is endemic in the developing countries. Genotype 3 has a lot of animal reservoirs, boars, wild deer, fishes, trouts, and the mode of and it is distributed in the Western world, as we just saw in the previous slide. Now, the mode of transmission of this was initially hepatitis E was thought to be a disease of the endemic world. So the only way the West could acquire hepatitis E was traveling to countries like India and to the developing countries. Now, autochthonous hepatitis E has been described as a very well-known entity, and this happens by consumption of undercooked meat and by other methods like blood transfusion, organ transplantation. But consumption of undercooked meat is how hepatitis E genotype 3 is transmitted, and that happens in the West. 4 is limited to China and Japan. Swine is the host. The transmission is zoonotic. 5, 6 do not have human hosts, and 7, as I was just saying, there is one case report of genotype 7 having caused an infection in a transplant recipient. Other than these routes, mother to fetus transmission has been documented for hepatitis genotypes 1 and 2, but not for 3 and 4. And blood transfusion is another known entity, is another known mode of transmission for genotype. All the genotypes of hepatitis viruses. So although A and E are enterically transmitted viruses, they do have a phase of viremia. And it is in this phase of viremia that hepatitis E is being recognized as a significant risk for when it gets transfused to recipients, specifically when the recipient happens to be immunocompromised. Now, by now we have understood that there are two distinct epidemiological patterns of hepatitis E. Genotypes 1 and 2 are prevalent in the endemic countries. They cause sporadic disease or outbreaks. India has witnessed a lot of outbreaks. In fact, it was during the investigation of an outbreak in the Kashmir Valley in 1978 when the first suspicion of another agent which was enterically transmitted was discovered. So it was then called non-A, non-B enterically transmitted hepatitis A. The mode of transmission is fecal-oral. Contaminated water supplies has been the classical mode of transmission of these viruses. Young adults are most commonly infected. Most likely the disease happens to be self-limiting. Sometimes it can lead to subacute liver failure or acute liver failure. Severity of hepatitis E in pregnancy is very well documented and known to everybody. On the other hand, in the West, where genotypes 3 and 4 are dominant, it causes infrequent sporadic cases, which are zoonotic, associated with either hunting or consumption of animal meat. And these infections, unlike the endemic world, these infections are more common in elderly population. And there is a tendency of these viruses to cause persistent infection if the host happens to be immunocompromised. So these are two distinct epidemiological patterns that we see. The virus, as I have said, causes sporadic illness and outbreaks in the endemic world. It is not easy to estimate the prevalence of this infection, be it hepatitis A or E, because a large chunk of the illness is asymptomatic. But it has been found that approximately 30% of the population is infected every year. Mortality ranges from 0.2 to 1% in the general population, which is pretty low. But then the mortality increases significantly when pregnant women are infected. In India, it accounts for half of the cases of acute viral hepatitis and 1/3 of the cases of acute liver failure. There is a very wide variation in seroprevalence of hepatitis C in the Southeast Asian countries, from 30% to 80%. And this is largely because a lot of different kits measuring HIV, IgG have been used. These kits have very varying sensitivities and specificities. So that leads to a very wide variation of what we can assume to be the seroprevalence of that particular region. It is important to note that the reported cases has increased in the European Union between 2005 to 2010. So we do not estimate seroprevalence for the West because there it is not a very endemic disease. It is just infrequent sporadic cases. So seroprevalence is measured largely for the developing countries where the disease is endemic. When any host acquires hepatitis E virus infection, the virus can either be cleared asymptomatically because of the innate immunity, the neutralizing antibodies, or it can cause a symptomatic infection. Both in immunocompetent and immunocompromised host, the symptomatic infections can also be cleared spontaneously because of the same immune responses, and it can lead to long-term protection. But in presence of predisposing factors like a pre-existing chronic liver disease, or if the patient happens to be pregnant, certain mechanisms, certain predisposing factors like high viral load, the inflammatory cytokine, certain polymorphisms come into play, and that can lead to setting in of acute liver failure. When the replication persists beyond 3 months, as is the case of immunocompromised host, chronic HIV infection is said to have set in, and this is attributable to impaired T cell responses and evolution of quasi-species in the host. So the clinical entities which merit a special mention are, we all know about severe disease of hepatitis C in pregnancy, decompensation of chronic liver disease, chronic cases or chronic hepatitis in the immunosuppressed, the extrahepatic manifestations for which the virus is infamous, and presence of HIV in blood products, which can be used for transfusion or transfusion-transmitted hepatitis E. So it is the recognition of these entities which has rekindled the interest of the scientific community in hepatitis E virus over the last decade and a half. A complex interplay of immunological and hormonal factors are responsible for the morbidity and mortality of hepatitis E seen in pregnancy. The effects on the uterus, like intrauterine death, neonatal hepatitis, acute liver failure of the uterus of the baby have been well documented. The mortality can be as high as 25 to 30%, reaching its peak in the 3rd trimester of pregnancy. Acute or chronic liver failure is a newly recognized entity, which is a decompensation of a pre-existing liver disease upon certain encounter with another decompensating factor. So this is decompensation in a pre-existing liver disease, and acute HIV infection is considered as one of the most common etiologies of causing decompensation in patients who have had cirrhosis, because which could have been alcoholic or which could have been attributable to hepatitis B, and the mortality rates for this are very high. So this is the worrisome fact. It can have high mortality rates as high as 60 to 70%. There have been a lot of studies which have looked for the presence of hepatitis E as the pathogen that has decompensated patients who have been cirrhotic because of some other pathology, and hepatitis E prevalence in these patients has been found to be as high as 90% in a study from Vellore to as low as 8% in another study from North India. So as you can see in this table, hepatitis C, it cannot be denied as a very important factor of decompensating liver disease patients. Extrahepatic manifestations of hepatitis E has also been dwelled into. A lot of these are existing in literature as case reports or case series, but it is the neurological and the renal manifestations of the virus which has been reported most often, and causality has been established for these manifestations. Guillain-Barré syndrome, encephalitis, and myositis, neuralgic amyotrophy, can be caused by the virus. There are a lot of mechanisms which have been proposed. Molecular mimicry has been suggested as the causative reason for the virus to cause these infections. Some studies have said that there are certain strains of hepatitis E which are more neurotropic. Hepatitis E can cross the blood-brain barrier. So there are certain strains which are more neurotropic. And there has been a theory of a compartmentalization of a particular quasi species in the CSF, which has led to these manifestations. And it must be noted that patients of hepatitis C who present with neurological manifestations, it is these neurological signs and symptoms which are common in the patient, and whereas the liver function is only moderately affected. Renal manifestations have also been seen not uncommonly, and it is glomerular disease which happens with hepatitis A. Transfusion transmitted hepatitis E is an entity which has taken the transfusion medicine community by storm, because in the West, high prevalence of HIV RNA has been found in blood donors. The prevalence has been as high as 1 in 600 cases in the Netherlands. This has been very well documented in many countries. England and Japan have studied it extensively, and there have been reports of hepatitis E being transmitted to recipients via blood transfusion, and the recipients have been immunosuppressed and they have gone on to develop chronic hepatitis E. So risk of chronic hepatitis E is the main concern. If the patient who has received the blood or blood product is not immunocompromised, means in healthy individuals, these transmissions often remain asymptomatic. But such high prevalence has made many countries mandate screening for HIV RNA in their blood donors. Countries like England, Ireland, Japan, Netherlands have mandated HIV RNA screening in blood donors because of this entity. Now, chronic hepatitis E, as we've discussed, refers to the presence of hepatitis E viremia in blood or in stool beyond 3 to 6 months, and this leads to progressive liver fibrosis. Solid organ transplant recipients happen to be the most vulnerable group of patients, although the other immunocompromised patients have also reported chronic hepatitis E. And it must be noted that most of these reports are with HEV genotype 3, which we do not have in our country. HEV genotype 3 is a problem of the Western world. In our country, what we have is HEV genotype 1, and with whatever evidence that has been generated in our country, it is believed that HEV genotype 1 possesses a very, either it does not, or it possesses a very limited potential of causing chronicity. So we have screened liver transplant recipients for evidence of chronic hepatitis E infection, but although it was found that patients have acquired hepatitis E, but there was no viremia, virus has always been cleared out, and the same has been replicated in renal transplant recipients. So these are short studies, these are small studies, preliminary studies, but with whatever evidence we have, genotype 1, which is our genotype in our hyperendemic region, does not possess the capacity to cause chronic infections, and this is quite reassuring that we do not have chronic hepatitis A in India from what we know now. The markers are the same. We depend upon IgM for acute infections, IgG. RNA is present in blood and feces much before the onset of infection. IgM antibody testing is the first-line diagnostic assay. There are ELISA-based platforms and CLIA-based platforms and alpha-based platforms which are available. Specifically, the some of the assays have really good performance. So it is a robust assay. The only problem comes in diagnosing immunocompromised individuals where the antibody responses are blunted. So HIV RNA has to be used as the first line for diagnosing the infection in the immunocompromised when you want to establish chronicity or if you want to monitor the antiviral treatment response. A lot of work has been done in developing the assay for HIV antigen. HIV antigen has dynamics which parallels the dynamics of the viral RNA, both in blood and in stool. So this can serve as a cost-effective alternative to HIV RNA testing. IgG is also a marker of seroprevalence, but again, the kits have a lot of variation in sensitivity and specificity, but it can also be used as a marker for protection. Genotyping of the virus is important to study the viral strain, and sequencing and phylogenetic analysis is important both for HIV as well as HIV because this is the way to characterize outbreaks. A special mention of the One Health concept has to be made when we talk about HIV infection because zoonotic transmission of the virus is happening with genotypes 3 and 4. So we know certain reservoirs. We know that swines, pigs are the reservoirs, but then there may be animals which are unknown reservoirs. The virus may also be found in environmental reservoirs like water, which is contaminated by excreta from these animals, or the crops which have grown by irrigation of this contaminated water. Shellfish has an ability to concentrate the virus and can serve as a reservoir for the virus. So it is important to apply the One Health concept to the zoonotic genotypes of hepatitis E virus as well. There is a vaccine available, but then it has been licensed only in China. There's only one serotype of hepatitis A as well as hepatitis E virus. So one vaccine works against all the genotypes. But then China has done some work, has shown good safety and efficacy in high-risk groups. But then WHO believes that there are further more studies which are needed upon the immunogenicity, safety, and protection profile in high-risk groups specifically. So no specific treatment is available except for ribavirin, which is used to treat chronic hepatitis E. And what we have to depend upon is improving sanitation and hygiene, making clean water supplies available, avoid contaminated food. Most importantly, as microbiologists, what we can ensure is good and robust diagnostic assays for hepatitis E and A, and vaccination of high-risk groups should be thought upon once the vaccine is available beyond China. For treatment of acute hepatitis E, which has progressed into chronicity in liver transplant or any transplant recipients, a trial of ribavirin for 3 months can be tried, and which can be extended to 6 more months if there is a relapse or if there has been no response. Interferon, pegylated interferon alpha, is also tried in patients of liver transplantation. So this was about hepatitis A and E virus. Comparing the two together, there are a lot of commonalities between the two viruses. Some parallels can be drawn, like both were discovered using immune electron microscopy from the fecal material from the infected volunteers. For hepatitis E virus, the lead experimenter was the person who ingested the sample himself, and hepatitis E was demonstrated in his feces. For hepatitis A, present inmates were used as volunteers for discovery of the virus. Both are primarily hepatotropic, positive stranded RNA viruses, and they largely cause acute self-limiting inflammation. Although they have distinct evolutionary histories, they have common ancestral roots, which goes back to the Picornaviridae superfamily of viruses. Both have the same forms: naked virion, which is excreted into the bile and then into the feces, which is a very stable form that is meant for the virus to carry out its transmission, and the quasi-enveloped form, which has a pinch of the host membrane with it that protects it from the host immune response, and that is the form which is circulating in blood. Both of them share a common route of transmission, and the endemicity of both can be related to the economic development and sanitation practices of the particular geographic location. And in childhood, these viruses cause asymptomatic or mildly symptomatic infections, and the severity of infection increases as the age of contraction of the virus increases. But then there are a lot of differences as well between the two viruses. Hepatitis E virus genotypes 3 and 4 are zoonotic. A does not have any zoonotic potential, and certain clinical manifestations like the high mortality of hepatitis E genotypes 1 and 2 in pregnancy, chronic hepatitis E, and a more predilection to cause extrahepatic manifestations are certain clinical manifestations which are important for hepatitis E, but they do not do not pose such an important risk when we talk about hepatitis A. Now, hepatitis E is increasingly recognized in the middle and high income areas. With the zoonotic potential, the incidence has been increasing. But hepatitis A, except for sporadic outbreaks which have happened here and there, the overall incidence of hepatitis A has been on a decline. We have an antiviral for chronic hepatitis E, ribavirin. We do not have any such thing for hepatitis A, even if it is causing acute liver failure. The serological diagnosis is more reliable for hepatitis A, but less for hepatitis C. The M capture assays for IgM, HEV are a little better. They do much better. And the problem with hepatitis E is often the patients have been previously infected. They have a pre-existing IgG already there. When the levels of IgG declines, the infection can occur once again. So these pre-existing IgG interferes in laboratory assays which are targeting IgM. And hepatitis A vaccine is a very robust vaccine available worldwide, whereas hepatitis E vaccine is not available outside China. Since the two viruses share a lot of commonness and most importantly, a common route of infection, co-infection of hepatitis A and E have been reported not uncommonly. So when we talk about the common modes of infection, both A and E are waterborne. They can be foodborne, specifically if the crops and vegetables which have been irrigated by contaminated water is used, so that can cause foodborne HAV and HEV. Blood transfusion has been implicated as a mode of transmission for HAV, but not for HAV. The ones in blue are unestablished routes of transmission. MSMs are high-risk groups for HAV, but not HEV. There are animal reservoirs of HEV, but not HAV. And vertical transmission is an important mode of transmission for HEV. Co-infections are important because both the viruses have the same clinical manifestations. Their clinically is indistinguishable. But then when both can infect a host simultaneously, it can lead to fulminant viral hepatic failure. And the mortality rate is much higher as compared to infection with a single virus. So to conclude, over the last 2 decades, progress in understanding human infections with hepatitis A and hepatitis E virus has been eclipsed because we have more important priorities at our hand today, as we've seen in this lovely webinar which has been happening. We have hepatitis B virus, hepatitis C virus, which cause chronic infections, and that is the challenge for the hepatology community. So A and D haven't really been worked upon. But then in that time, a lot has happened with these viruses as well. The global burden of liver disease caused by A and D have both increased. E has come up with a lot of newer entities. For hepatitis A, shift in epidemiology has happened. So the risk hasn't abated. Because of vaccines, hepatitis A has become increasingly a disease of adults instead of early childhood in many parts of the world. So that is the reason why there has been a change in the age of acquisition of disease, leading to more severe disease. E has remained endemic in many developing countries as well as in the developed economically advanced countries. It is now very well recognized as a cause of chronic progressive liver disease in individuals with compromised immunity. So with this, I end my presentation. Thank you. And I sincerely apologize for the technical glitches that had happened.
Thank you so much, ma'am. It was a very nice presentation. And we are also sorry because of all this thing. But yeah, there were quite the audience were also very much into it, and they have quite a few questions for you. But I will be sending it you through email so that we can revert back them through the mail. And I want to thank you once again for this wonderful presentation. Thank you, ma'am.
Thank you, Abhishek, and I'm sorry for the glitches.
No, it always happens in such online things. Okay, thank you, ma'am. So
Thank you.
to conclude this session, I would like to thank everyone on behalf of the organizing committee, especially our speakers, my teachers, Ekta ma'am, Ashok sir, my senior, my mentor, Pragya ma'am. All of them, they said yes in one go. And their presentation was very, very fine, and quite a good amount of knowledge was dispensed to everyone. I also like to thank for all the participants who were actively engaged in this virtual event. Your enthusiasm was highly commendable, and we would like to thank you all, and we would like to see you once again in future also. A special thanks to our Executive Director, Sir, Professor Dr. Colonel Katoch, Sir, for his unwavering and unflinching support always. And thanks to our organizing committee, my head of the department, Colonel Agarwal, Sir, my coach colleagues, Dr. Anil and Dr. Mayuri, and our residents, Dr. Kinjal, Dr. Bhumika, Dr. Shakshi, our technicians, Jinkal, our ICN Radha, and one of our old JRs, Dr. Prakash. And a special thanks to the technical team also. And last but not the least, heartfelt thanks to, and I bow down before the Almighty. And yeah, thank you once again for being a lovely audience, and have a great weekend ahead. And we'll be sharing you the e-certificates within, like, as soon as our CME gets over. And thank you once again. See you soon.